After getting our hands dirty with UBE, we were always trying for anything more, and then the role of navigation started to come in, and I recently started doing image-guided endoscopy fusions. Our center recently acquired OARMs over last month only, so I have a very superficial experience, around 9 to 10 cases only with image-guided endoscopy, but these 9-10 cases in my superficial experience has been really wonderful, and so I would be talking about the essence of image-guided endoscopy. As we all know, UB is powerful, but with guidance, we can give potentially better results and can make this thing more safer and versatile. We'll wonder why image guidance we use in UBE and what is the role of image guidance in UBE. As we all know that with the endoscope, we have higher magnification and better visualization, but in narrow corridors, and at a time we are only able to focus on one area into the spine pathology. There are a lot of anatomical variations, patients variation. We can have different type of patients, like obese patients. We can have deformities in the spine. So we need to have a working 3D anatomy in our minds while we are operating with the endoscope, because unlike the open surgeries, we don't have everything just in front of our eyes. Here in the endoscopy, we are seeing a very limited anatomy at a time. So what does UBE brings in? UBE gives us a third dimension, or rather I would say a fourth dimension, which enhances our vision indirectly and makes the surgery safer by bringing in the multiplanar imaging into the, in real time we can use that and make the surgeries safer. Using navigation, we can have more precise bone removal and decompressions, whether we are doing it just on one side for a simple disc, or whether we are doing fusion surgeries, or we are doing multi-level surgeries. This navigation guidance really comes in handy to give more accurate and precise results. And the foremost thing which I believe gives the surgeon the best thing, which gives this navigation thing to a surgeon, is less of radiation exposure. Rather, I would say there is no radiation exposure while performing UBE surgeries when we are using navigation system, because once we capture the images at the starting of the surgery, when there is nobody in the OR when the images are being acquired, and once the images are acquired, then we do not need any radiation or anything inside the OT, so it decreases radiation exposure significantly to the surgeons as well as the staff in the OR. What are the limitations of standard UBE? We rely on 2D images, which are the only thing we have in the OR, which can help us guide the surgeries during our performance of UBE surgeries. As we can see here, these are the kind of images we usually get, in which at multiple times in our surgeries we need to have images, we need to orient ourselves whether where are we, have we crossed to the other side on the from the midline, we are near the facet, or we have how much isthmus we have drilled, or how much isthmus is left. So these are the things which we need to consider while performing safe surgeries, but that entails a lot of cumbersome work. Every time we need to have an imaging done using the C-arm, and then we need to assess it on the 2D images, which is giving us more radiation as well, and taking a lot of time. Because of we are not using navigation system, for the beginners, it's a steep learning curve, because they need to have crystal clear 3D anatomy in their minds before embarking on the journey of UBE, because anatomy of the spine is, as we all know, it's not that simple. We need to visualize it in our minds virtually. Where are we working, in which manner we are drilling. So that need that kind of orientation is that comes with the experience and with the in the initial days. That is one of the challenges which we all have seen in our practice. Sometimes there are unexpected intra findings when we are not sure what we are seeing at. In those cases, again, it comes in handy when we are having the navigation guided system, which tells us exactly where we are and what we are looking at. What is the role of O-arm, or in certain cases 3D C-arm also suffices? So what's the role of these navigation gadgets in our day-to-day neurosurgery or spine surgery practices? Using navigation, we can have real-time multi-planar imaging, just like we are sitting on the console in the radiology department while when we are planning for the complex surgeries or multi-level surgeries. We usually go to the department, or we are seeing it in our console at our desk, uh, where we are able to see a single point in three different dimensions. So without navigation, that is not possible. The MPR imaging is not possible without navigation. But when the navigation or the imaging we are having at hand while performing surgeries, that really improves the results, and it makes the things for the surgeon a lot easier. With the help of navigation, we are able to localize the pathology accurately. Sometimes when we are doing multi-level work, we get confused where we are, whether we are above the disc space, are we approaching the isthmus, or how much facet we have removed, how much it need to be removed. So at these junctures, the role of O-arm navigation comes into play, and that makes our lives easier. While doing decompressions as well, we can know in real time how much we have decompressed, what are the bony structures we have removed while performing surgeries, and it gives us the real time feedback that this much work has already been done by you. There is no need to go further, and you can stop at this time, and this is sufficient for this patient. Minimizes unnecessary bone resection, as I've already discussed, decreases radiation exposure, and the other thing is surgeons fatigue, both physical and mental. When we are struggling, it's during surgery, apart from physical stress, it gives you mental stress, and that again compromises the patient's outcome, because when we are not having a fresh mind, then it leads to altered results or not the efficient results. So what are the clinical advantages of using the navigation in UV practice? It makes the decompression safer and more precise. It, for the beginners, it shortens the UB learning curve, because they are more confident while performing surgeries. They don't have to actually recall everything in their mind virtually, that I need to perform this surgery, and where I'm drilling, what are the structures I'm encountering during the endoscopy. So if they are having this system in place, so it makes their life easier. Reduces revision surgeries, again due to the same reasons I've already described earlier, and improves confidence in complex anatomy, especially in the fusion surgeries. When we are doing it in first few cases, it defines the anatomy in a beautiful way just in front of our eyes, so we are able to see the anatomy in a more precise way, and we are able to carry on with the surgery in a better way. Once we are adapted to this navigation system, I would agree that in initial few first cases, two or three, four cases, the tech people, the technicians in the OR, the anesthesia people, and the surgeon himself, it takes longer times for us to register the patient and to perform surgeries using the navigation guidance. But once everyone is acquainted with the system, they know how to proceed with the surgery using the navigation. It significantly reduces the total time for the surgery. In TLIF, what are the benefits of using image guidance? While performing TLIF, the benefits are multifold. It helps us in putting accurate port placement for disk access. We need not be worried about whether we would be having perfect triangulation or not. We are seeing the things in real time in front of our eyes, and we can plan the things accordingly. Safe neural decompression before cage insertion. We know that what are the bony landmarks we have removed, or what are the things we needed to remove. Do we have enough space for cage insertion? Have we taken care of whether we would be needing retraction to the nerve, or we can go more laterally, and there is space we can go use it from the lateral side to insert the cage safely without much of retraction in the nerve root. The beauty of the UB, as we all know, is we can actually see the end plate preparation, and using UBE, we can see the bleeding from the end plates. So the fusion is of higher quality, and using navigation thing while performing the end plates, we know that we are not harming the bony end plates, only the cartilaginous end plates we are removing. And same way, while inserting the cage, we can see in the real time what is the direction, what is the angulation of the cage, what is the size of the cage we would be needing. We don't need to have trial and error there. We can use the simple calculations on the navigation system itself, and it would tell us that what are the cage sizes which we can use, and what is the trajectory. And while inserting the cage itself, also we can see in real time the way cage is going in. As we all know that using the navigation system, we can increase the safety of putting in the pedicle screws, because we are seeing it in 3 dimensions while performing the while inserting the screws in the cases with TLIF. We can see in 2 different views simultaneously that we are going in both axial as well as the sagittal sections, and it increases the safety of our screw placements. The other thing I would like to highlight is the kind of sutures or the kind of scars patient would have. This is a patient in which we did UB TLF using the navigation guidance. Here, while performing TLF with UBE, we don't need a linear scar on one side. We can simply have 4 small scars, and patient is having a better cosmetic result and less of tissue disruption, which in post-op results in better outcome. So what is the workflow while performing UBE plus navigation? First of all, patient planning, where to put in the ports is the standard thing which we all do. Then I'll just wrap it up. Okay. So, second thing is we do an O-arm spin, and reference point fixation is done on the spinous process 1 or 2 level above. While acquiring these images, all the OT staff and the surgeons go outside of the OT, and at that time the images are taken, and that's the only time the radiation is there in the OR. And once the images are acquired, we need not have imaging this radiation in the OT again. Third is a standard endoscopic decompression is done using, whenever we need any guidance, then we can have the navigation guidance during decompression as well. Then end plate preparation is done. Fifth is cage placement is done in the standard way. And the last thing is percutaneous screw placement with the navigation guidance. This is the workflow, standard workflow when we are doing a tail lift using the navigation system. So this is a case demonstration, just a short video. These are all standard procedures. Here I haven't shown any screw placement using image guidance because that's a standard thing, so I haven't shown that. So early outcomes in my limited experience with 9-10 patients only, it has reduced the radiation exposure considerably for me, and it has now started. I have started doing it in a shorter period of time. The whole tail lift thing. After once we are confident and we are conversant with the technique, it has increased accuracy in decompression as well as the cage placement. And screw trajectory, of course, we all know. It has increased my confidence while performing the UB tail lift surgery because I exactly know what I'm doing. And it has reduced complication rate in my practice. Future directions regarding after what after this image guidance, I would say this is AI assisted pathology segmentation. What need to be done, how much screw size we need to be done. It would be real good if some AI can give it to us that this is the plan of this is the plan for this surgery. AR/VR platforms that is yet to take shape, and robotics are being used in few of the hospitals, and we intend to buy one someday, but that is still far of dream for me. Take home message is basically UB navigation is safer. It makes the surgery safe and smarter, and gives more confidence to the surgeon while performing the surgery, and expands UB into fusion applications and makes UB as easier for new adopters. Mind it, navigation is not luxury; it's the new standard of care. If you can afford it and you can install it in your hospital, I would definitely say that it is worth spending money on. So I would just conclude my presentation here, and I would like to announce that we'll be conducting a UB exclusive endoscopic spine conference in February 26 in New Delhi, and you are all invited for this academic feast. Thank you all.
Thank you, Dr. Gaurav, for bringing in the future extensions of the UB. Like, I mean, I'm pretty sure like this is going to be the future using navigation and doing it. As you mentioned, like, I mean, it shortens the learning curve for the beginners. If you have the facility available, its OAM is expensive. It's not easy. Dr. Gaurav has the luxury of having it, but not everyone has it. Definitely, and even for those learned ones, like, I mean, who are already there in the UB, the doing multiple levels, and particularly at the cervical, because it's a crowded vertebra and all those issues are there. To I mean, like typical OYLs and cervical, multiple level lumbar decompressions. I think it must be a very useful thing, and even along with the fixations. If you have the O-arm using it for fixation, I think you should use it like for marking to changing levels to everything. I think it's the future, and thank you. Is there any other? It's open for discussion.
I was quite interested with the OAM you are using in UB. Have you like only in fusion or even in district
In two
or
cases,
canal stenosis?
yeah, in two cases I've used it in simple
How do you
stenosis.
fix the plate?
Sorry,
How do you fix the frame,
the frame, the reference
the
frame.
reference frame?
So it has to be fixed on 1 or 2 level above onto the spinal process.
You do that.
Yeah.
You open
So
up, given one extra
yeah,
incision,
because
and,
otherwise
and
there is no way
fix
out.
it in.
Yeah.
Okay, told you that because I had also one case with OAM, and that was not a fixation actually. And I learned that with from the team of Sun City Hospital and Dr. Ajay Kothari and all.
Mhm.
What I do is I just paste it with a plaster at one point. If I'm doing canal stenosis or UB discectomy, because that doesn't require exact precision. That will only need to guide me whether I'm in right bony landmarks or not. So in that case, what I do is I fix the frame and tape it.
Okay.
And after that, I do all the landmarks. And once I inside, I just put that universal
Frame.
receptor frame in my one of the wand that I'm dissecting, and I just check at times at what landmarks I am.
That's a good
Just
input. Yeah.
interested with that. So
Yeah.
what you are doing, because if you are doing UBE and doing
You're
a
giving a separate
discectomy,
scar.
one
So
extra incision
yeah. So,
for a frame
yeah,
insertion,
I
that
know
would be
that's a concern because you're giving a separate, a longer scar rather than
yeah.
the UV surgery itself. So, but yes, that's a good way to do that actually. So I would try that
Thank
in
you.
next case. Yeah.
Since we are running out of time, one question and then we'll
It's not a
continue
question.
with the
This is the, I mean, if you want a less scar, it is better to fix that into the iliac bone. You hardly have 2 mm of incision for that. And the other thing is, as you said, you can even suture that, the universal frame to the, and the other thing is, when you can place the iliac pin. You can suture it and plaster it.
Yeah, because there's a concern always means while performing this, we are giving an extra scar for just reference frame fixation. So listen. No, I don't
thank
put-
you for the wonderful discussion, and thank you, Dr. Gaurav. Now the next speaker is Dr. Krishna. I would like to request Dr. Krishna to present the memento to Dr. Gaurav.
I thank Dr. Nikunj for the invitation and for a wonderful event. It's my first time in Nepal, so I have my friends like Amit Thapa and Gopal Sadain, like who I did neurosurgery, and as well Gopal Sadain was my undergraduate batchmate as well in Banaras in the university. So I always wanted to, but it's excellent. Like to be, the hospitality is great. We had the Pashupatinath temple and the other Vishnu temple. They were all memories like so much shared for the between India and Nepal. Like I mean, it's so too that we do. And I come from here. That's Hyderabad. A lot of our friends are here from 3 of our colleagues, and that's the hospital that I work. We work over there at 12 posts. So part of the perspective of UBE, like I mean, emanates from it. We have to maintain the numbers because the administration puts huge pressure on us to not to postpone or have longer waiting lists. So that's when, like, I mean, the issue of while we do the other cranial part of the surgeries, which are complex skull-based surgeries and other things, that takes the entire day OT. We have 4 operation theaters dedicated for neurosurgery. But the problem that comes is, as Dr. Amul Reje was mentioning, what is the efficiency of doing it? Like, I mean, what is the, in one of the things he was asking about, what is the time period? The time period, learning curve, and everything. I don't have the luxury of time, I mean, taking 6 hours for longer periods. You can take for the initial cases, but not for longer periods. So, how to build in efficiency while we do these procedures? That's what my focus is. And I learned as when we got the system, like I went to Atmaranjan for a couple of days. Then I went to Professor Ang, like I spent a couple of weeks. And recently I had the opportunity to see Dr. Park operating in Delhi. So since that was my alma mater, I could get into the operating room and be there and ask him like whatever things that were there. So that's where our learning curve, it has really, these are some of the people, they have done fantastic work in bringing in efficiency, safety into the procedure and making those learning curves much shorter. So that was, we had in China, like in Chengdu province where Dr. Professor Yang works, like we had wonderful time every evening. Like, I mean, the food and the city was absolutely amazing. So that was Dr. Park. Like, I mean, we were having a discussion on the next case in Ames, Delhi. And the last he attended, he did the workshop there. So I'll just straight away go to the dorsal OVL. I come from a region, like, I mean, the one which I have shown on map is the region where we have very high concentration of endemic, the ligament ossifications are endemic. I did 6 years residency in Ames. I mean, I hardly could see 1 or 2 of ligament ossifications of the OVL, the yellow ligament in the dorsal spine. So, but in our region, the OPLL and OVL are very common. Like, I mean, so much people blamed on fluorine, but I doubt. We are just now putting on research projects to look at other aspects of these things. So, the OVL is one common factor that comes, and here this gentleman comes like is around 50 years, comes with dorsal compressive myelopathy, and he has ligamentum flavum ossification, and which is on one side it is there. So there's some tips that we generally encounter in these things. I mean, as I said, the anatomy that we have to learn is it's like lumbar. So for everything, I mean, when you go from the posterior aspect, the first thing that you want to find is, are you there at the interlaminar space? So it's you land at the spinolaminar junction. The next immediate place that you get into is interlaminar space to clear the muscle to seeing everything and all those things. So the important thing that we have to note here is in the thoracic, the spine comes because it's very easy to go to a wrong level in the thoracic, and it's so you count ribs. If you don't know, I mean, where the spinous process stays, where the interlaminar space, I mean, you'll end up in a lower level, and you start doing it. Then probably even the C-arm doesn't help. So it's important for us to know that the spinous process and the extension of the spinous process and the lamina covers almost to the upper 1/3 to the mid of the next, the vertebra below. So because the moment you see the interlaminar space, you start going up, tracing the ligamentum flavum, drilling and looking at these things. So the same thing on the X-ray, how it converts to B. Our C-arms are not so good always to show everything. If the patient is obese, like, I mean, you go bad. So this is the lamina outline. So the rest of the things are all what we see in the do in the laminar. So you land at the spinolaminar junction, and the working port and camera port are on the same 3 centimeters. The working port has to be well in line of the decompression that you do, because you can't be drilling, I mean, with too much angulation. So that's what you want to avoid. So the thing, I mean, the other thing that we learned from Dr. Park was every level, the moment we localize the level, we want to inject methylene blue, because there's only 2 or 3 shots that you take in the beginning. Then you take out the C-arm. You don't have lead effluents. That's the pleasure of operating the case. So then comes the, you don't want to be burdened by the UBE surgery. That's the way to take the program forward and faster. So you inject the methylene blue. When you land in, you start clearing the muscle. You see the methylene blue. You are sure that, okay, you are confirmed. And you deal. So in that way, you bring in, you cut the time. Every time, I mean, you keep shouting in the CM, the worker has gone for his lunch, dinner, he got to the other OT. So by the time he comes back, you lose another 15, 20 minutes. It's a lot of saline, everything that you're pushing in while all this happens. So And once you localize that, you want to just a last confirmation that you do is like, I mean, you just do drill that one, perch your drill there, uh, drill a small outer cortex of the lamina, perch your drill there and confirm it. It's much faster. So then how do you clear the muscle? Muscle, like, I mean, use the 15 number needle handle, use that one to the wider thing, I mean, to be able to clear these things. And yeah, that's the thing. Yeah, this it's all standard thing which has already been taught. So the other thing that we have used, I mean, I learned this from one of the UB surgeons from Guntur, Dr. Naresh Babu. He, in a problem like, he started using the bone scalpel. So he said, like, yeah, I mean, this is the way I can build in efficiency, because I have to operate sometimes 3 cases in a day. Big cases, both cranial, this, that, and shifting between the OTs. So we started using this, we use the Mesonic scalpel here, and it makes it so safer and so easy for, hope this video is running. Yeah, okay. So that's our, the assistant professor. So that's the interlaminar space, like after we clear it. And the other things like how you clear the muscle, everything, I mean, it has been talked by a lot of surgeons, so I don't want to repeat them. So once you confirm it, then we drill part of the lamina here, the outer cortex. Then then cuts with the Mesonic scalpel starts. It's absolutely good. I was telling the pair, the business executive, international relations of the bonds, you are not coming up with the business the bone scalpel, then you are going to lose business. So, and probably it has to be far more adaptive to the biportal, because some of these things, like, I mean, people use the different tubular portals for both the working channel and the camera. I generally use only portals for the camera in the camera portal, and we don't use it for the working portal, because in the working portal, I mean, you want to use any larger instruments, then that gets a little restrictive with the space. So this bone scalpel right now in its current form is the one CUSA that we use for the tumors in neurosurgery. There are finer tips, but still they are bigger for any tube to be accommodated in, any tube to accommodate themselves into the tube. So here, I'm just, we go in, like, I mean, we just keep cutting the bone, then we're seeing it. I don't use RF, like, I only use the coagulator, the plasma one, at lower settings, coagulation, and lower settings of ablation for hemostasis. The biggest problem in the UB is how you control the hemostasis. Earlier we were shifting between, we were so scared in the beginning, like we were shifting between plasma and RF. Every time, I mean, the machine has to be shifted from plasma to the RF. Then someone will take a lot of time. And there was someone who is sitting on the stool all the time there, I mean, to shift, like once you are closer to the epidural space. I said, it's okay. We have now avoided that problem. No more stools at this machine, I mean, to change these things. So you use the ablation settings and other things in different angles and other things, I mean, for using. So this one, you cut the rest, everything is like the way you did the decompression in the lumbar. You use the we did the bone scalpel, we have cut underneath part of the spinous process, then lamina and everything, like, I mean, was done. It's a pretty smooth, bloodless field, clear, safer, everything. So, but you should not go on an overdrive with a Mesonic scalpel, because you try to put in pressure on that, it will plunge into the cord. So, but it doesn't cut the soft tissue. That is the biggest safety. So that's where, I mean, all these surgeries probably in future would be replaced by the robots. I probably foresee how things are going to come up. We may not be required for many of these cases where the moment some machine can distinguish between the soft tissue and the bone and can stop at that point, which the Mesonic scalpel already has achieved. So probably a lot of these things are partly robotic. Yep. You are there as a watcher, only supervising that. Okay, this is done. So that's the decompression that we achieved. That's the window that we created. And that's the patient who is walking. Yeah. So yeah, he was okay. Like, I mean, see, he has a little spasticity, but definitely improved than much before. So our guys made him to even the upper limbs movements as well. I asked them to send a video. So operated for the legs, but they'll make them do the upper limb movement. Anyway, that's the one. So then coming to the cervical laminectomies, as I said, I come from the region where OPLL is so endemic. We operate so many of these OPLLs and do these surgeries. So as we have to do 3-level laminectomies, 4-level laminectomies, and end up doing fixations for a lot of these people. And quite often the biggest problem of doing lateral mass fixations and doing laminectomies is someone who has the myelomalacias and other things. See, one of the partial deteriorations come because the cord has shifted and it caused further traction on the cord. One of the possible causes of deterioration. So we shifted to the as we gained experience, we shifted to the laminectomies in this. So, and the advantage of these laminectomies that is when there are multiple levels of OPLL. Generally, you go in and do from all the way from 2 to 6, 2 to 7, or whatever. And so the upper 2 and the lower levels still may not be, the OPLL may not be so thick to really cause a lot of compression. Since you have seen it on the CT, you don't want to go for a second surgery, you will do the entire of that one and fix the. And how about having a cervical lateral mass fixation of, yeah, we are ruthless in fixing cervical spines and think that, okay, we haven't done it, my X-ray is good. So ask the patient, I mean, who wants a very high quality of life. He will tell you, like, I mean, how bad it is on his neck, the stiffness and everything that he feels, the restriction. You can always put figures here, but it's good. It's only that when people go through these surgeries, I mean, people get to know. So the biggest thing that we can avoid in most of these OPLLs is fixing. So how about the technique wise, there are 6 levels that we see. And there are 2 levels or 3 levels is the significant severe compression. We will only do those levels. We will leave the rest of the levels. And if the patient comes back, we saved them the fixation, have retained their movements, everything like without much restriction. Patient comes back after maybe 5 years, 10 years. It's not even 5 years. The OPLs don't progress in 5 years. They are more than 10 years, 15 years before they actually got to the level of compressing the cord. So you can just kind of do the next 3 levels. You are happy because if you are in private practice, like, I mean, you can do 2 surgeries on the same patient. The first surgery you have delivered the outcome, he's more than happy, like, to pay you the second time. Okay, so the business builds up well. So this is how we do it. Like, see the AP views and the lateral views. The lateral view in the cervical is the conformation. In the AP view, you are just paracentral. And the lateral view, you are being on the lateral view is must in the cervical to see the level conformation. You are landing on the, you just see the alignment of the pedicle of that patient, then do it. So what is the principle? The principle is we start from here, you undercut this and undercut this spinous process, go over the top and do it. There's no sublaminar drain cervical. There's not so much space. So it's like using an upcut, going underneath the lamina and trying to punch it where the canal is already severely compromised. So it's a over the top decompression. Only these things keep hanging in the air. And this retains the posterior ligament complex of the cervical spine, which even in trauma and other things, we give a highest priority to assess whether that is stable or not. So that's what it is retaining. It has a sling effect, so the entire column is preserved, so you're doing well. So how it goes, when you have to do multiple laminectomies, we start, yeah, it's a little, say, we start at this, the level that you want to do, we go on the level, initial lamina is the one which is a little difficult. Once we knock off this lamina, the upper lamina and lower lamina, you have access to the opposite side too. Once this goes off, we have access to see the opposite side of the upper lamina and lower lamina. So it gets much easier. So the initial lamina is the one which, so maybe like, it's easy to get lost initially how much you do, how much of contralateral you drill, how much of the spinous process. That's where what Dr. Gaurav has used. If you have the O-arm or navigation, I mean, use it. It shortens your time period, make it shorter. So this is a patient of 55-year male, progressive difficulty, spastic gait, compressive myelopathy. And a lot of these patients, to be only thinking that we are doing cervical compressive myelopathy, relieving cervical, that's absolutely wrong. Some of them have, a lot of these patients have radicular pain because there is equivalent foraminal stenosis there. If we are not decompressing the foramina well, so that's not going to settle. So UB addresses both the things in a very efficient way. So that's where this is the OPLL. If you see this guy, he has almost on one side, it occupied 3/4 of the diameter of the spinal canal. So which is a very high risk of deterioration post-surgery because of the thecal sac expansion and other things. So this is, yeah, this one. So I see this he has even foraminal stenosis on one side. We place the patient don't flex the neck, because if you flex it, the muscles are taut, they keep closing your path. So we mark the midline, confirm the level. Then the next thing that comes is the incision is just paramedian and methylene blue. It's very important. I mean, it makes your procedure faster, easier, and less confusing for you once you land on the. So after the clearance of the soft tissue is done, generally we do the lamina in the central lamina when we do 3 levels, then above and below part of it, and we can keep clearing the tissue later on. So we thin out the ipsilateral lamina, outer cortex, cancellous, and the inner cortex, you eggshell it. Just till the time you see through that bone the yellow ligament, but don't take out the entire lamina. So then we start moving towards the opposite side. The biggest problem that comes here is how much of, because the spinous process is tented in the center, it's tenting is there. So, but the opposite spinous process is much lower than the tenting of this the spine you see. So when we get onto the spine to just get the level of the opposite lamina, you see the lamina below, which is in an oblique fashion for you. Clear the muscle over there and see and get the sense of like how much depth you need to drill. So the cervical spine is obviously the low error zone. Like, so you can't obviously like go on. So you have to be far more careful, and so then in this we used a combination of cutting drill initially, then we shift to the diamond. In cervical there is no cutting drill, like it's only a diamond drill, because the cutting drill swirls the tissue, you can't see the things well while we are doing it. So only diamond and Mesonic scalpel if you have it. So Dr. Bansal has the O-arm, we have Mesonic scalpel now. Yeah, I'm done. Oh, it's beyond. Okay. So that's the thing. This is the floating things. Okay, I'm concluding. This is the window that we created. So this is another patient. Like, I mean, we even like we did the. He has also severe radicular pain. We decompressed the opposite foramen. So that's a. This is the better way of doing it. Thank you for this one. Say, thank you. So
we are running out of time, and we would reserve the questions for at the end of the session. And I request Dr. Bansal to provide the certificate and memento to Dr. The next speaker is our renowned endoscopic spine surgeon, Dr. Deepak Esther from Ubecon Hospital. Thank you, sir. Stage is yours.
Good afternoon, everyone. First of all, I would like to thank organizing committee, Dr. Balgopal, Dr. Nikunj, and his team for organizing the very wonderful, very academic conference on the UB. And I would like to thank everyone who has been a part of this team, a part of this event, especially from faculties from India. Most of them I already knew, or I have already heard of them. So it's very nice time to again come back and to discuss it about. So I will be talking about the section of OIL. Most of the things will be kind of repetitions, because the Dr. Krishna has already presented the technical part. But sometimes the repetition is good because it is important. That's why it has to be repeated. So repetition does not always mean that it's just by luck or by fluke. It's important, that's why it will be repeated. So how many of you have experience of doing the OIL by open technique or the microscopic technique? So please you raise your hand. So I just want to keep you awake. I know that most of you have done it. So if you are awake now, let's move towards the further discussions. We know that this is one of the commonest cause of the thoracic compression and resulting the myelopathy. And depending upon the morphology, how extended towards the midline, or whether it's unilateral or bilateral, or whether it's bridge or not, The various morphological classification has been done for the OIL. And and we also know that the once the symptom has set in, or the sign and symptoms has set in, the only treatment we have is the surgical resection. And how many levels, at what levels, that depends upon the which level is the symptomatic or not, what is the size, what is the morphological type. But unfortunately, the post-operative complications after the resection of OIL is very, very high. It has been reported up to 33%, and various kinds of complications can occur. So the gold standard until a few years back is the open or by the microscopic, and you know that there are very high complications rate with the open techniques, for example, dural injuries, cord injuries, or the post-operative infection. I don't know how do I operate the video. Can you just click on that? Prolong, or your soft tissue dissection is very large, then obviously there are high chances of the also. But nowadays, the endoscopic technique can be used for the OIL also, and it can be like a uniportal, or it can be a biportal or UBE technique. So since this is a UBE event, so we'll be talking about the UBE technique. And what are the advantages of a UBE for the OIL resection? Because we have now very good optics. You can very clearly visualize what you are resecting, where you are working upon, and you have a very good hemostatic now equipments for the coagulations, and it has given a very good advantage in the literature regarding the OIL resection with the UBE technique or the endoscopic technique. So it also shows that we need to be familiar about this technique for the OIL. And obviously, there is the advantage of the endoscopic, as I said, that it can give a very good visualization. You know what exactly you are resecting. You can very clearly delineate between the neural structures and the other structures. You can have a very good hemostasis. So these are all advantages of OIL. The technique, I will not go in detail. The making the portals is more or less similar to what we do for the lumbar discectomy. Depending upon the site or depending upon the dominance of your hand, usually the dominant hand become the working portal, and the non-dominant portal become the visualization portal or the scopic portal. And you have to dock at the spinolaminar junction of the superior vertebra or the cranial vertebra. So this is a kind of a semi-edited video of the 42 years female who had OIL at the D11 and 12 level, having the early features of myelopathy, and as well as the severe tingling, numbness, and the radicular pain along the dermatome of the D11 and D12. So can you play the video? So this is the CT, and you see that once you have delineated your site of your interest, what we do is that we put the small K-wire at that site and take a CM picture, and that K-wire and that picture or that small dent at the spinolaminar junction become now the regular reference point if you are get disoriented. So once you now delineate your target, then your drilling starts very circumferentially. First, the inferior border of the superior lamina. Then you go towards the cranial side. Then you go to the spinolaminar junction. Then you work into the superior border of the inferior lamina. So that you have to, circumferentially thin out all the outer cortex, because in the thoracic vertebra there is not a clear-cut interlaminar space, unlike in the lumbar vertebra. So you have to make that interlaminar space by removing the portion of the bone from the inferior lamina of the superior vertebra. So I use I think we talk about whether use the reverse or the clockwise or anti-clockwise of this diamond drill. So I found that the reverse is very effective, and as well as the safe also, because it does not entangle the soft tissues, and as well as if you inadvertently goes inside, then instead of going forward, it will push you back. So I think the using the diamond bore in the reverse is a safe and is effective also, because the diamond bore works into the the sandpaper. Either you go forward or backward, it will cut, unlike the other type of the burrs. So once you have thin out the outer cortex, then you will reach towards the ossified yellow ligament. And always we have usually as a surgeon, we have a intention to remove the whole part of the yellow ligament in a single bulk. So that may not be a very good idea. It is always better to remove in the piecemeal. Even it is, there is always a, you have an inner a kind of ego that I want to remove it as a single piece or the block. Sometimes that will be a mistake also. So what I do is I usually use the micro pencil or micro hook to dissect the yellow ligament from the undersurface of the dura, so that even if it is very free, I usually do not pull it, because the pulling the yellow ligament can also stress the dura and as well as the neural element also, and that might injure it. And another thing is, do not cut the yellow ligament circumferentially at once. You have to remove it from the one side and then come to the other side, usually from midline to the lateral, because if you make it free from circumferentially, that it will be floating, and if you want to just make thin out, in case you cannot remove it, then it will be not possible, because it will not have a support. So at least keep the one side cortex, usually on the lateral side of cortex, intact, unless you are 100% sure that you are not removing the whole ligamentum ossified ligamentum flavor. So keep at least one cortex intact. And if you have to use once it is very thin out, if you have to use 1 mm caritions is the safe. And there are different kind of caritions. I usually use the caritions used for the cervical, which has a very thin and base plate, so that it does not injure the neural structures. And I use this hook, RF hook, and this is very useful not only for the not only for the coagulation, it also for the dissection also. So I think most of you are having the lab cholecystectomy experience, so you have a hook probe, so you can retract it, dissect it, and at the same time coagulate it and cut it. So this hook RF is very, very useful in dissecting the underlying erosion. In this particular case, I have removed the portion of the facet also, because this patient was very symptomatic in the D12 and the D11 Norwood dermatome. So I want to make sure that it is Norwood is completely decompressed. As now I'm palpating the axilla and the shoulder of the Norwood. So make sure that it is free, and hopefully the patient will be symptom free after this deroofing of the Norwood. And I finish the surgery, of course, with the drain. And as you can see that how nicely all the soft tissues come back once you remove your catheter. And you can also see that how less soft tissue injuries. And this is a pre-op picture and the post-op picture of the patient after the surgical dissection of OIL. And this is I didn't have a pre-op clinical video, but this is a 1 month post-op video. And you can see that this is on the other side, this is a 1.5 year post-op picture. And you can very clearly see that how much she has improved in the gait, and as well as, of course, she is symptom free from the radicular pain and the numbness. And you can differentiate the gait pattern between the immediately after the surgery and in the subsequent follow-up. But there are some dangerous or the cautious signs also. If you have a shortened radiological signs, for example, tram track sign or comma sign or the breach sign, they may not be a very good candidate for even for the complete resection of OIL, because you might have to leave certain portion of ossified ligament, because these are the signs of the dural calcification. So you don't want to take a risk of the dural injury as compared to the complete resection. Sometimes you can just keep it floated, thin OIL floated also. But if you have a dural injury also, with the UBE, small injury, you can just leave it. And you can measure the size of your dural injury by the size of your probe. So you know what is the length of your probe. Then you can speculate that how big is your dural injury. If no neural elements are coming from your rent, you can just leave it, for example, around 5 millimeter. And if you have to patch it, you can use the tachoseals into the different layers, so that you don't need to repair it. And if it is a very large defect, then still you can repair it with the UBE. So this is not the same case. This is another case where I have a dural rent. Can you just click on the video? So if you have a dural injury, you can use the very, very simple instruments what we have in our OT. Can you just click the video, please? So if you have a knot pusher, most of the, I think the surgeons know what is the knot pusher. So if you have the knot pusher, you can use the, put the 1 or 2 sutures with the UB also. So this is another case where I had a dural injury and I decided to repair it. And this is a, similar, I think 60 or 70 suture, and this is a knot pusher through which you can, throw the knots and tie it inside. And once you have a, 2 or 3 knots, and if you're happy or satisfied, then you can just cut it. And this is very simple technique. There's no rocket science in this technique also. And and one thing you have to keep in mind is that the defect what you see may not be big or may not be very large, because you are already looking through the scope and it is already enlarged. That's why you see that even a small range is a very big. But if the neural elements are coming, that you need to think about the suturing and the repairing. So I thank for your kind attention, and hopefully I can convey some messages on the UV. Thank you very much. Any questions?
Thank you for a wonderful lecture. It's not repetition. Like, I mean, you have brought in like very minute, micro details of these things that definitely needs to be taken care during surgery. So absolutely, thank you. And how often, like, I mean, you just leave that bone, because some of them, like you have shown, where the dura is calcified. Generally, you tend to just do a free float drill and just leave it for free float.
My first baseline is that I always go inside that probably I have to leave something. So I put that, sentiment that I have to leave something. But if it is free and if I think that I can remove it, I will do it. But I don't hesitate to leave it some portion of the elbow ligament calcified. If it is very adherent, or if I might risk of injuring the dura, I leave it also.
And the other important aspect in this is if you have a bilateral OL, you are free floating, just leaving the bone there. So it's important that you do a pedicle to pedicle decompression, like from all the way from through and through, like from left to right. Like, I mean, the entire pedicle to pedicle has to be felt, has to be drilled. Otherwise, it's then post-operative CT scan is going to give you a shock. Like, okay. So anyway, thank you. Any other questions from the
I have one question. Like when there is dural tear and the nerve gets protruded and entangles to develop a omega sign, just it entangle into itself. So there will be entanglement of the nerve root. So how will you unwind those nerves and repair?
You see that whenever you have a dural injury, the first treatment is have a patience. So you have to really be cool yourself and think how to get make it solve. To push your neural elements coming through that rent with using the small gel foam or the whatever you have. So make sure that little by little it goes inside, because it may take time, but it has to go inside. Otherwise, you cannot repair or you cannot decide it. So it takes time. And sometimes what I also do is I take a small bite at the one edge, so that it can be stretched and you keep it little wider and open, and you push all the neural elements inside. And once the neural elements are inside, sometimes it's like a ball valve mechanism, so it does not come outside now, because it is now stretched and it has gone back into its position. Then you decide the size of your dural defect, and if it is very small, it's not coming out. I have experience that in the very initial stage, I saw the dural tear, and the first principle what I learned is that once you have a dural tear, you have to repair it. Then when I opened it, I didn't find the dural tear because with the scope, I saw that small rent very big, and that kept in my mind. But when I opened it, there was no dural tear. So it has automatically, has come back to or oppose each other. Yeah, probably I have understood your question and answer.
Exactly not, but then they are entangled to itself, and it will create a omega like.
Okay. So you have to just use a micro pen fill and trace the whatever you can trace it, and then push it back into the wherever it's herniating or coming out. You don't have any other options to do rather than that. I don't know. I'm not aware about any other
Yeah,
techniques?
recently, in one case, unluckily, I had a dural tear, and the nerve protruding was winding into itself.
Okay.
So I had a hard time to unwind it, and gradually, as I said, with
So
patience,
I don't
could-
know any other way that how to untangle or how to unwind that tangled knob root, but probably you just need to use the micro pen peel or micro hook so that you can trace it and then keep it back safely.
Tangle more rather than relieving on its own. So as Dr. Deepak did say, put some patch of either a cottonoid or a Sergi cell and then try to push it, but never put water on it. Because these nerve roots just by irrigation is not going to go in. They will come out more further.
Thank you for wonderful talk and good discussion as well. Now, Dr. Rakesh will present. Oops, I'm sorry. Dr. Suresh will present the memento speaker. Don't mind me, I'm very bad with the names. Yeah, Dr. Sai Kalyan is one of the stars in Hyderabad. Like, I mean, as I know him, it's so now he'll be Sai Kalyan. Okay.
Well, good afternoon, everyone. Well, Dr. Vamshi, I would take it as a compliment. First of all, I would like to thank Dr. Nikunj and Dr. Balgopal sir for giving me this opportunity to present my work here in front of you all. Yeah. So after having a heavy and yummy lunch, this session everyone feels very drowsy, and but I will try to make it more interesting by adding some spice and masala to it, particularly the Indian and Nepal combo masala. And this presentation is about my journey in spine techniques and approaches, and how I tailor the procedures for its particular pathology. All of you maybe wondered what is this book about. To put it very simple, once upon a time there lived two mice and two little people in a cheese station called. See, it is a hypothetical cheese station, and every day they used to come at 9 o'clock, and without notice of the, they used to eat the cheese silently and gossiped, did some work, and went back to home by 6 p.m. As what we do, we go in the morning to the hospital, finish the work, and come back. And soon they started thinking that yes, the cheese will be there forever, and they are in that comfort zone. So suddenly change does come, because change is the only thing which is always constant. And in this story, one day, to their surprise, they found that the cheese owner found that silently these people are eating, and he stopped keeping the cheese there. And among the four characters, Mr. Hem was very upset with this. He didn't want to come out of this comfort zone. And Ha, who is most like us, he startled by the change, but ultimately he compromised. Yes, we need to adopt this change. And Sniff and Scurry are very, they are very intelligent, and they are the entrepreneurs like our Deepankarji. So they accept and embrace the change very soon. So this is how it started. So after finishing off my residency, and the span of 6 years, I was fortunate to do good number of micro discectomies. But I was surprised with this meta-analysis, which have demonstrated that tubular discectomies, micro discectomies, provide additional advantages with regards to better ospecific disability index, that is ODI. So I went to none other than the pioneer of tubular discectomy, Professor Mehmet Zeleli, and learned and came back and started doing these cases of tubular discectomy. with 22 ports, and I confined again later, around 12 port, and I was giving good results, and I present this work in many international national platforms, and after doing some 100 cases. So one day, when I was in my OPD, a patient insisted that no, I don't want tubular, I want only endoscopic surgery. At that time, I trusted more in tubular discectomies and tubular surgeries rather than endoscope. So their instance has pushed me to learn the endoscopic surgery, and I began step by step. I didn't want to rush myself, so I started with, the basic technique, that is the Descendo technique, because the investment was very less in this. But I started doing good number of cases. I did around 30 cases. But the challenge here I found was, when you go higher up levels, it was very difficult because you need to drill a lot of bone, and fogging was, quite common. The scope used to get, bloody very often. And so somehow I was, okay, but still I used to do, if someone asked me about endoscopic discectomies like this, with this procedure. So next, again, as you all know, this endoscopic surgery, has become the gold standard, and they soon said that soon it is being replaced. It will be replacing the, traditional microscopic discectomies and tubular discectomies. And so I thought, yes, it's a time for us to learn. And of course, if you see this slide, if you look at the Taj Mahal from the entrance gate, it appears majestic but distanced. As you move closer and zoom in, the details become very clearer and it's more captivating. Endoscopic surgery gives such similar experience. It brings your eye right to the desired place, whatever you want. So I went to Germany and learned there, and I came back and I started doing the uniportal surgeries. So, but the challenge here was, again, it was very cumbersome because I used to get fatigue very soon, and I didn't find the free movements, range of movements, and the difficult challenge for me was to see the exiting routes, and higher up levels were also very difficult. But somehow I managed doing some around 40 cases, and I was okay. I was satisfied with this. And the other challenge was the hardware is very expensive, and the consumables were also very expensive, and not all the patients, because I work in a multi-specialty hospital, were some people were affordable and some people were not. Then I met Mr. Pritam, who is a local bonds distributor, and he made me meet this gentleman, Mr. Dipankar, and he said, sir, you should definitely visit Professor or Nikunj Yogi. I say he's Mr. Perfect. So you can see here how passionate he is about this teaching. So he has changed my perspective. I was not interested, to be honest, in UB, and he had given some of the tricks and trade. Of course, you can see Bal Gopal sir also here. The first thing, second thing, you can able to see the tissue, the desired tissue, very near, and the main advantage is we can see the exiting routes effortlessly in this case. And he also told me, look, Sai, if you go back and if you don't do the cases, you're definitely going to forget. And the first thing which he told me was about the position, the triangulation, and the C. You can see that C there. So if these three things are correct, 70% of your procedure is done. And one more thing, what he told me was it is exactly similar to that of microdiscectomy, but the tissue which we are seeing is very near, very near. So, and I was fortunate enough, and by God's grace, I started, doing, and till date I have done 44 cases in span of 4 months. But I, after attending some of the workshops in between, I started learning from others' mistakes first, and the transition should be in a gradual manner. And in the early part of the learning curve, these were things these were the indications which I wanted to tell to the young surgeons who want to start this. To start with, it is on the left-sided L5S1 extruded disc, followed by L4-5 extruded disc, central disc, followed by over-the-top laminectomy. Next is a foraminal disc, and then you go for the endotelif. And before operating, I was not now, even before, when I was, there was some transition from one technique to other. I was very particular about these things. Obese patient generally I used to avoid unless until I was, I gained some, experience in it. Second was the facetal arthropathy. Third is the medialization of the facets, ligamentum flavum hypertrophy. Of course, opposite side disc and foraminal disc and calcified disc. It's better to do it at a later stage. So intraoperatively, all these things we all know, but the only disadvantage, what theoretically they say, that you don't have we don't have 3-dimension in endoscope, but with repetitive dynamic scope movements, our brain builds a mental 3D map. That is, we call it as a pseudo 3D anatomy from this 2D screens. So once the triangulation is achieved, what Nikunj said to me was pause, focus on the endoscope lens for the RF probe. This ensures a clear visualization and helps the precise instrumental handling. And RF probe handling, should be a distance from the RF probe to the scope, or else you are going to bang the, the scope. And maintain adequate distance between the drill and scope as well, and avoid accidental contact to protect both the scope and the field of vision. So creating a 3D sense is again a challenge. As I said earlier, endoscopy offers a 2D view. So rely on your tactile feedback over bony prominences to develop the depth perception. And trust me, you will be getting that 3D view easily. Patience and practice gradually improve the pseudo 3D orientation. So if you can see this is one of my first cases, the L5S1 extruded disc. And it was, it gives you so happiness if you remove such a big disc. And later you can see the axilla of the root and the thecal sac and shoulder, which has been removed. So this is the other. So I thought next I'll go to next level, and I started doing calcified disc. And the same thing on the left side. Of course, you need to have good instruments here. The Spino UB by Bonds and Easy Ablator by Bonds are really helpful in ablating the tissue and coagulating the tissues. So here I'm using these instruments. And once the retraction is done, you can see a big hump of calcified disc here. And later I started drilling because I was unable to pass the 15 number blade. And discectomy was done. After the discectomy, I could find some more bulge. And there was some subligamentous disc complex which I could remove. And again, inferiorly, just near the shoulder, there was some annulus which was entrapping the disc fragment, and I removed that. So here the entrapped disc fragment has been removed, and now by using this Spino UB, we can annuloplasty can be done easily. Next is I wanted to go to next level by doing the over-the-top decompression. This is a case of L4, L5 severe canal stenosis due to ligamentum flavum hypertrophy, facial arthropathy, and disc bulge on the both sides. So again, having the C in your field is very important. So this is again drilling. Drilling, I I follow Dr. Nikunj. He told me 30,000 RPM in reverse. Definitely you're not going to go and bang the thecal sac which is there anterior to you. So with the help of the different instruments, we can gently separate the attachment of the ligamentum flavum. You use Carrison punches, scoops, and this technique I have seen in one of the videos of Dr. Anindya Basu. He uses this probe, right angle probe, to ablate the tissue with low settings, and this is how we did. If you can see here, I have exposed both the traversing route, ipsilateral and contralateral side. The opposite side discectomy is also being done, and we can also see the opposite exiting route there and ipsilateral exiting route. So now coming to right-sided pathology, the right-sided pathology addressing from right side. So the scope is in the caudal part and working channel is in the cranial part. Here again, Dr. Nikunj told me you are seeing C from the left side, but when you come to the right side, you need to see a reverse C. Have that in orientation. Rest of all is the same. You try to drill it till the attachment of ligamentum flavum. A proper flavotomy has to be done in the initial thing, but make sure that you're not going to obliterate or violate the facetal capsule. And after this, I use very meticulously the Carrison punches, and it is same like microdiscectomies where you bite it, don't pull it, because underneath this we have Hoffman's ligament and spinomeningeal bands. If you try to pull it, the dura is going to get torn, and you can see the noodles, which you don't want to see actually. So this case, after doing you can see a good hump disc bulge. So annulotomy is done, and once the annulotomy is done, the disc fragment is expelled out. You remove the disc, and annuloplasty is something like soldering thing. So there was an osteophyte which could be drilled, and mind it is not possible. I mean, it is not possible for me, at least in uniportal systems. So next, one of my close friends, Dr. Ahmad Ansari, has taught me this. He said, why can't you do it right pathology from the left side? So I stood on the left side. As you can see here, I'm addressing the right-sided pathology. Of course, it was L5S1 disc. You can see the spinolaminar line, laminofacetal line, and also the inferior lamina. And I made sure that there was adequate interlaminar space before I ventured into it. And after removal of the outer layer of ligamentum flavum and inner layer of ligamentum flavum, see, it was just a fenestration. No bone was drilled here. So once you remove the ligamentum flavum, you can see the traversing root shoulder and retract it, remove the disc. And once the discectomy is done, the procedure is same, do the annuloplasty. And here we can see the axilla of the root, the shoulder of the root, and the thecal sac. Next, this is a case of right-sided inferiorly migrated disc with L4-5 canal stenosis. The patient had a severe canal stenosis. So this is how you drill the superior aspect of inferior lamina, the superior lamina till attachment of ligament flavum. Again, flavotomy has to be done. And here you can see I am with the Carrison punch, I am removing the drilled part of superior aspect of inferior lamina because I wanted to go to the foramen. It was inferiorly migrated disc. And after retraction, again the procedure is same. Do a annulotomy, remove it. After removal of the disc, annuloplasty is done and over the top decompression is done. Well, later I wanted to extend this and I had a discussion with Dr. Nikunj how to proceed with this, and he gave his insights. So we have a OAM navigation with this, and it has been there for the past 4 years in our department. And now we reached a milestone of 200 cases of spinal fixations. And in addition, we run a structured program in collaboration with Medtronics to advance the knowledge and surgical skills. So I have done 3 cases of navigated guided UBE TLIF. So here we can see medial fascectomy is done. Once the medial fascectomy is done, the ligamentum flavum has to be kept intact, and ipsilateral and over the top decompression should be done by using a drill. And you can also use the undercave procedure, what Dr. Atmaranjan does. So after this, we can be able to remove the ligamentum flavum beautifully as shown here. And once it is done, we again go, we prepare the for annulotomy, and the procedure is same. Do the annulotomy and do the discectomy. The shavers can be passed, and we can prepare the end plate. And the good part about this is we can see the end plates very clearly. There is no overzealous end plate preparation here. And once we see the cartilaginous end plates, you can stop there, place the bone, and I use all expandable cages. And as you see here, we have good adequate cartilaginous end plates. And after placing the bone in situ, we place the cage here, and later the screws under a navigation guidance. Here you can see the pre-op X-ray and the post-op X-ray. But before we need to learn the open TLIF first. Of course, all that glitters is not the gold. It's not gold. So here this is one of the cases where I punctured the dura. As our previous speaker said, these things are not, like Dr. Vikram said, it was not a big tears what we see. It was a small tear, and I don't know whether Dr. Nikunj remembers or not. He told me to pass a pen field and see. You come to know what is the size of the defect, and defect was very small. So I thought I'll place some artificial dural substitute as a hourglass technique and some soldering effect here, and I could come out. Of course, this everyone should concentrate, please. This was a case which I encountered after performing 30 cases, where overconfidence began to overweigh your logical thinking and surgical safety. So I knew that it was a severe ligamentum flavum hypertrophy with thinned out dura, but still I thought that's okay, and I tried to pull it, and you can see a dural defect. That's okay. Then again, I realized that you should follow the basic steps. I tried to define the dural defect here, try to remove the ligamentum flavum which is compressing, and very gently somehow I could find that it was around 4 mm. I didn't have proper logistics to repair it, and I placed dural substitute. The mistake which I did was I placed the suction on the scope. And can you see here in the 12 o'clock position, some noodles were visible. Then after removing this, I could see that they were very good noodles. So I had only 2 options. If I had a proper equipment with me, I would have sutured it. But so why your open anatomy and your previous tubular or whatever is very important is, here in the same incision, I have placed multiple dilators, and I used a tubular port, and with this I was able to repair it under microscope. So these are some of our cases in 44. So we have converted two cases. One was this case, and other case was, I need to tell what we do is we have a resident. I mean, I have one resident with me. So he has kept the position, and I went, and there was a dural tear. But to my surprise, after the dural tear, I was seeing that these things were popping out, as a noodles. So I was very surprised why it is. Then I could see that the Boulser was exactly above the umbilicus. The intra-abdominal pressure is also very important. So right from first, it is better you be there and have the have the proper positioning of the patient before doing all these things. And there was another complication. Of course, this was one of the first cases which we did, but the patient had spondylolischitis at the above level, and it came out to be a tuberculosis. So we have evolved like this to this. And this 3-level decompression I did, and I shared with Dr. Nikun. She was very happy. Somehow I was able to complete it in 4 hours. Luckily, we came out without any deficits. And to put it very short, I require 1 more minute. So please put your ego outside and scope inside. All that glitters is not gold. Know the open anatomy first and tailor the technique according to the pathology. There is very steep learning curve. Get well trained. Try to meet good mentors like Dr. Young, Dr. Nikunj, and Dr. Balgopal sir. And quality comes first. Please remember, quality comes first. And quality comes with the cost. It's a bitter truth, but quality comes with cost. Okay. So this, I mean, you can take a picture of this, which is better, and accordingly. Thank you for your patience.
Thank you, Sai Kalyan, for a wonderful lecture. I think we are beyond time. I guess we should give Nikunj the time to inaugurate the conference. So not now, like coming later, because we are already running an hour and a half late. So thank you for. So the next speaker, Suresh BK. And by the way, like Deepankar is a conversion mafia. Like, I mean, converting everyone from open to the biportal, monoportals to biportals. So absolutely. Yeah. Yeah, Dr. Gaurav will present the.
Okay.
Yeah, Dr.
Just-
Nikunj, why
just-
don't you do the honors, please? Like, yeah.
Just a
Please.
comment from my side regarding the dural tears. Whenever you encounter dural tear during the endoscopic surgery, two words of advice, two lines of advice. First of all, let it settle down. Let the CSF egress. So once the pressure inside the dural tube decreases because of egress of the CSF, so it is easier to put the noodles back in. It gives you less force from inside to outwards. Second thing is, while you are putting it in, ask the anesthetist to hold the breath, right? So that with every breath, it pushes the noodles out. So if you ask the anesthetist to hold the breath for 10, 15, 20 seconds whenever you are working on the sac, so it gives you that much of time to repair it in a better way.
And the most important thing is we need to stop the irrigation.
Yeah, irrigation has to stop.
Okay, moving on to the next speaker, I humbly request the next session and other further speakers to be in time. Are already quite late, so remember.
Warm good afternoon, everyone. Slide, please. So over the next 15 minutes, I will talk about how to avoid complication in UV. Since from the morning, we have been looking into a lot of surgical videos and a lot of complication as well. So the danger with UV surgery is the dural tear, but there may be bleeding. So those things should be taken into consideration and should be avoided. So my topic is cutting risk and boosting bliss in UV surgery. Wait, the slide is not. I have no conflict of interest. Spine surgery has progressed tremendously in recent decades. There has been a paradigm shift with the introduction of minimal invasive spine care. In 1909, the first lumbar discectomy was done, which later in 1977, microscopic discectomy has evolved. Then it was until 1987 when Parvin Cambion developed the percutaneous posterolateral discectomy. Later, Jung developed the minimal invasive endoscopy, and in 1996, arthroscopy has been used. And it was until 2013 when Solomon developed the UV techniques. Though your UV surgery is minimal invasive, it is not devoid of complication. That's why a thorough understanding of this complication and strategy to prevent them should be understood. The first and the foremost important thing is the patient selection. The optimum patient selection is the key for safe UV surgery. Pre-operative assessment of the MRIs, looking for the disc morphology, the canal status, even the height of the bony anatomy, whether there is any transitional vertebra or sacralization of the spine, whether there is any high riding iliac crest, these things should be considered. Even the medial facet hypertrophy should be taken into consideration pre-operatively. For discectomy, the indication are herniated lumbar disc, Oda equina syndrome, lumbar stenosis, but UV is contraindicated for grade 2 or higher spondylolisthesis, post-op lumbar restenosis, bilateral foraminal extraforaminal stenosis, and vertebral fractures. With the localization, with the help of CM, the target level is identified and the vertebral end plates are parallel and squared. So when the endoscope visualize the working instrument, then that is the triangulation. So the triangulation is the key for safe and sound UV surgery. This should be done with the help of the C-arm guidance in AP and lateral projection. The interportal distance should be optimum. If it is too narrow, then there may be instrumental crowding. And if it is too far, then the tissue dissection and the disc access will be difficult. For multifidus muscle detachment, with the help of the RF, the tissue from the spinal laminar junction should be dissected off towards the lateral lamina, and the facet should be exposed. The fluid medium is the key, another key for UV surgery, and 100 centimeter height of the saline bag, providing the pressure not exceeding more than 30 millimeter mercury is optimum. For bony exposure, with the help of the drill, the bone dissection can be started from the spinal laminar junction, thinning it out and leaving an XL cortex and progressing it towards the lateral side till the facet. So this will expose the whole of the of ligamentum flavum. This can also be done by osteotome. The osteotome is safe technique, and the chances of injury to the nerve or the thecal sac is less. And while using the Kersen pons, sometimes the tissue can be inadvertently taken by the bite of the Kersen pons, and that can cause injury to the theca as well as in the nerve. So while using the drill, I suggest to use the drill perpendicular to the bone, so that even if there is slight change in the movement of the drill, it will be guarded by the lamina itself. For phlebotomy, once the complete superior lamina is drilled, till the attachment of the ligamentum flavum, then it will be easy, and the upper margin of the ligamentum flavum is free. So once it is free, then you can proceed more laterally, so that the lateral attachment of the ligament flavum will also be free. And this way you can get a floating ligamentum flavum and can be raised backward and taken in a piecemeal or in a partial ligamentum flavectomy. Then the soft tissue covering the annulus will be dissected, and there will be epidural fat which should be exposed with the use of the pituitary rouncer, and the annulotomy is done with the help of the annulotome, and it is suggested to puncture the annulotome parallel to the knob root. so that the chances of injury to the knob root or the thecal sac will be minimum. And even you can use the thecal sac or the knob retractor so that the thecal sac will be protected from the injury. There you are seeing the retractor that is protecting the thecal sac, and the discectomy is being done. So I'd like to share our experience of complications while doing UV. So over the period of 20 months, we operated on 97 patients with UV for simple disc surgery. And the post-operative complication we encounter is in 7 cases, which is 7.2%. The dural tear was 2%, foot drop was seen in 1%, discitis was also seen in 1%, residual disc was seen in 2%, and paresthesia was seen in 1%. This dural tear is not uncommon complication and should always be taken into consideration, because the chances of dural tear can be as high as 8.6%, which is more frequent in the thecal sac or in the axilla or in the traversing knob root. While doing decompressive surgery, sometimes the insufficient dissection of the ligamentum flavum may obscure the fold of dura, and while taking the ligamentum flavum with the Kerrison punch, at that time there may be injury. Sometimes the meningovertebral band or the ligament, they are attached to the posterolateral surface of the thecal sac, which may be inadvertently torn while dissecting the ligamentum flavum. Sometimes the hydrostatic pressure, if it is too high, it may cause infolding of the dura into itself, which may be taken into Kerrison punch, so should be considered. I personally feel like the risk of dural tear is more with the Kerrison punch, because if there is inadequate dissection and you are trying to take the ligamentum flavum, then that can cause the dural tear, which is also with the drill, because the slippage of the drill while doing the surgery can directly damage to the thecal sacs. That's why the bony work should always be completed before opening of the ligamentum flavum. Osteotome is somewhat safe in that case. Sometimes it can be of size less than 1 centimeter, more than 1 centimeter, can be in the central or sometime in the lateral part of the thecal sac, and the management technique has already been discussed. A root injury is uncommon complication, incidence of around 0.25%. It can be caused by the physical force or by the thermal injury, like with the use of the Pons drill or the Kerrison Pons, and even the instrument like the pituitary ronser that can cause the injury to the knob root. The thermal injury is also notorious in causing dural root injury, which can be direct. Like sometimes the direct contact of the RF probe can cause knob root injury. Sometimes indirect injury because of the increase in the temperature of the fluid, that can cause indirect thermal injury to the knob root, so which is pretty less controllable because we cannot control the temperature of the RF system. But the tenets and tricks is there should be continuous egress of the fluid so that the rising temperature will be washed off, so that the indirect injury of the knob will be avoided. So the good patency of the egress is of paramount importance. And to prevent the thecal sac or the knob root injury, once you open the ligamentum flavum, the energies should be at minimum. It should not be above 1 or 2, and it should be in the coagulation mode of setting of RF to prevent those injuries. The residual disc is not uncommon. It is accounting for around 2.3%. Even in our cases, we have 2% of residual disc. Sometimes in preoperative MRI, the disc size is pretty big, and just taking good amount of disc, it will give you a sense of security that you have taken most of the disc. So you may be overestimating this discectomy. So the residual may be there. So that should always be looked into. Sometimes switching the endoscope and the working port will give a different angle to the disc, and those discs hiding at the crevices of the knob root can be taken. You can even use disc hook to search the disc around the axilla, or sometimes it may be in the subannular disc. So those things also should be looked into. Sometimes discs may be calcified, which may need more aggressive approach like use of the drill. Epidural hematoma is not uncommon. Actually, it is more common, but the surgically warranting epidural hematoma is very less, just 1.2%. So there are various factors which we don't take into account, and these are the factors like during the time of extubation, there may be poor anesthetic control, which can lead to increased sympathetic activity and a rise in the blood pressure. Once you close the wound, there may be epidural hematoma. Sometimes because of the high irrigation pressure, some blood vessels may be obliterated. So these bleeding will be obscure and that they will present in the early postoperative period. In a patient with obesity, coagulation pathologies, or in a patient with NSAID, these things should also be considered. So there should be control extubations. You should be communicating with your anesthesiologist so that the extubation is smooth and there is sympathetic activation is prevented. And the use of the low frequency radio frequency ablation or even use of bone wax gelatin or the controlled irrigation systems, these all measures will help in avoiding the complication of epidural hematoma. So the patient's safety is important and it should outweigh the ego of the surgeon. And never be too shy to convert your endoscopic discectomy surgery into open surgery because the revision surgery will be difficult because there will be disorienting anatomy. There is already scar in the surgical site and the bony landmarks has already been abolished. So the C-arm reorientation is very important in a revision surgery and that your incision should be more lateral, more in the more clear anatomy area. And approaching from the lateral side and proceeding medially, it will be safe in a revision surgery. That's why the cadaveric workshops, hands-on UB workshop or training from the expert is important in mastering the UB. That's why you will sweat less during the time of surgery. So these are my conclusions. I think I finished in time. Thank you.
A wonderful presentation, Dr. Suresh. I don't have any question for you. I just have an observation to share. Like the previous case which Dr. Sai presented. So usually when we are removing the phlegm from the opposite side and due to the water pressure, the dura tends to fold upon itself. So if the view is not clear, you tend to chip on that dural fold, which can present as a dura tear later on. And also when we are using a 90-degree RF probe, so like we should make sure it is away from the dura always. Thank you.
Thank you. That concludes the session, and I request them to present the memento and the certificate. Continue with the next session, and in between for a tea break, maybe we can go turn by turn and bring our tea inside the room and continue with the discussion and the session. So may I request the chairpersons of next session to come on the board and start the session. Thank you.
May I request Dr. Balaraj Shekhar, Dr. Deepak Shrestha, and Dr. Prakash Kafle to kindly take their seats onto the stage to host the upcoming session on nuances and complications. Thank you.
Welcome to the session. So I welcome Dr. Amol to present from the topic on transition from open microscopic to UV surgery, initial learning curve. Welcome, Dr. Amol.
Dr. Palcharya and all the team for inviting me here. So there's hardly 15-20 people left. But anyway, any one of you who don't do UV in this room, so this lecture is meant for him and some seniors. Most of you are experts, but I'll try and motivate this gentleman to start UV. So how you do transition from open or micro to UV. Whenever I get an invitation in Nepal, I never refuse. I've been here for your spine courses. I've done the ABC, EBC treks, and I really enjoy the hospitality here. So as I said that this is an inspirational talk. It is meant for spine surgeons who are practicing open or microscopic surgery, who are elderly people like me and want to start with UB, or a young spine surgeon like this gentleman who wants to start endoscopy. We are all used to these open surgeries and microsurgeries. Now, what is the block which prevents you from converting from the traditional surgeries to endoscopy? One is your mental ego. What is your mental ego? That my results are good, my OPDs are full, my patients are praising me. Why should I change my technique? And there is the underlying thing which is there in your subconscious. Can I really learn and execute this new technique? Okay. So elderly surgeons like me always will criticize the younger population that they are unnecessary doing this, showing off. And secondly, there is a physical block. You know, you have stiff shoulders, stiff hands, carpal tunnel, etc. And there is a learning process that is tedious. Saying no to Carrison's punch, using the drill constantly, all these things you have to overcome if you have to learn a new technique. But what motivates the change is the patient's outcome. Okay, there is no compromise on the target job. So this was my first discectomy, which I did. And as you can see that this is the pre-op MRI, that's the post-MRI. Okay, so you leave no trace. I mean, the radiologist may not even report that some surgery has been done. So there is no compromise on the target job. Secondly, there are less complications, less infection, less bleeding, lesser hospital stay, less post-op pain, and less tissue damage and less pain. So all this motivates you. So this was my first case way back in 2019. And I said, this is a brilliant technique. I'm going to stick to this. So even though you are doing a good job, you can still motivate yourself to change. And surgeons thirst for learning. Okay, even if you're old, you can still learn. Patients' demands and expectations. That somebody say, patients will come and tell you, I don't want microscopic, I want endoscopic. In my city, which is the city of endoscopic capital of India, they come and say, I want with a laser, okay, in the OPD. That is too much to fill, but at least you can do a good job. And the cutthroat competition. In my center, everybody was doing endoscopic spine surgery. And people used to come and ask me, patients used to ask me, will you do endoscopy? I used to say, no, no, that is all rubbish. So that is the ego, okay? I don't want to learn a new technique. You have to overcome that ego and then you can get along. So what motivates to change compared to monoportal? Again, I tried learning monoportal, but I am not a very skillful surgeon. I am not a very intelligent or intellectual surgeon. I could not just learn it. I tried my best, but I gave it up. And the basic advantage I thought in UB is that you can deal with all pathologies in a cheaper, less expensive manner. And that is why I started doing UB. And the beauty is that you can access the anatomy is the same. There's no new anatomy to learn. What you've been doing for years, you're going to do now. Almost the similar steps. The field and the spatial relationships are the same. And if you land up in trouble in your early cases, you can always convert to open. Okay. Here in the monoportal, you're doing under local and you have to do everything different. Less expensive, same standard instruments. You just need one scope, which is also very cheap. So when you start changing from the traditional, you first assess where do you stand. First of all, you need to have an experience. Okay. So those who have experience with uniportal or transforaminal endoscopy can perhaps learn faster. People like me did not have much experience with endoscopy at all. But I had done a lot of knee arthroscopies. I knew what was triangulation, being from orthopedic background. So that was my ace point. Then you have to equip yourself with knowledge, with training and mentorship. So there are a lot of standard textbooks available. There are a lot of articles you can read about. Then non-visual anatomic appreciation. When you open or do with microscope, it's a visual anatomic appreciation. So experience in open surgery will always help you. First, see that your open or microscopic surgery, you're ace in that. And study with help of bone models and practice on the bone models outside. The triangulation technique, which we all know, is most important. The Scopy portal, this we have all discussed. So practice triangulation, use a simulator. Training, you can do short-term observerships, cadaveric workshops. So this was my initial training with Dr. Jim Hua, Dr. Hua, and Dr. Song. Cadaveric workshops, conferences, and the first teacher in medical profession is the cadaver. So that will help you a lot, like we saw yesterday. And then attending conferences. This is the recent World UB conference which was held in Korea. Then once you have learned, then you go back to your hospital and suddenly you find, how will I start? So you first create an infrastructure, create a team, okay? See that you have the scope, drill, RF, and you train your people. So this is the OT setup which you need, the video trolley, the C-arm, everything has to be working. But most important is training the human personnel, okay? Or your team will be fed up initially, your anesthetists will be fed up what you're doing. Then case selection. So once you have trained yourself, once you have created the infrastructure, next comes case selection. So start with the left-sided PID, lumbar canal stenosis, then right-sided PID, then finally fusions. And then you go to advanced learning like paraspinal approach, then thoracic, cervical. So other thing in endoscopy which is different is drill, drill and drill. Don't get tempted to pick up the Carrison. You know, that is one big barrier when you start from open or microscopic to Carrisons. And then you identify the tip of this flavum. I use cannulas, which I find very helpful. So you all know this. Stick to the principles. Always confirm the level. Finish all your bony work first. Use a diamond burr. Detach the flavum is the last step. And the Carrison Ronger's smooth part should be against the nerve. Always see the tip of your instrument. Know your radio frequency settings, etc. So always work above the fat layer, okay? So that that fat layer will protect you. The blind spot of UB, before your instrument comes, that is the blind spot. So be aware that your instrument may land up somewhere else and you're thinking that you're still waiting for the instrument. But once you start, after a few cases, you start removing this like that, you start seeing their post-op MRI, you get a thrill and you will not leave this technique. And finally, you insert the drain. And so you should be able to deal all the complications, tissue interference, bleeding, dural tear, extravasation of fluid, which has already been discussed today in a lot of lectures. And remember, there's a learning curve. Nobody of us here is born with the skill that in the first case will be perfect and you will finish in 45 minutes. There is going to be a learning curve. And these are the articles on learning curve for discectomy decompression, 58 cases. So don't give up, okay? Learning curve for fusions, they say it's 34th case on the 400 day. So anyway, don't give up, just pursue. You may take time, you might give up in an occasional case, but don't give up. And mentorship, after some time, you need mentors to progress. So I've been lucky, Dr. Park has come and visited our institute, performed surgeries. I also visited him. So initially you are clueless, what is happening you don't know. Then you become very confident. Then you get complications and you become realistic. And finally you achieve it. And the last step, so virtues. So you need passionate, you need patience. And the last stage is that when you start training your fellows and your residents. Then it will be well, practice triangulation, get a good mentor, attend cadaver courses, check your inventory, train your team, choose simple cases as the first is going to be anterior approaches and posterior traditional surgeries from C1, C2 to S2AI. So I welcome you all. Thank you.
Nice presentation, Dr. Amol. Really inspiring for the young generation, especially. I open the session for any discussion or any questions you have. As Dr. Amol rightly said, if you have no complications, some surgeon says he has not created any complications, then he is lying to the core or he has not done surgery at all. So don't be afraid of the complications. Listen and learn from the mentors. That's very important. So any questions?
Okay, I hope you got motivated to start UB. Thank you.
I think if no questions from the audience. Dr. Amol is, I think many of us know him, that he said he's a very good friend of most of the Nepalese spine surgeons. He has been to the AO spine course and many other activities also. And regarding this lecture, do you use the drain for all the cases for the single level
I do
discectomy?
use a drain for all the cases.
And what's your now experience so far? That is it really necessary?
I just cannot afford a complication. So there is usually some drain there, 20 ml, 40 ml, but it is better than having a epidural hematoma and re-exploring a case. So I
Do you
actually in the microscopic I don't use, but
don't
here I
use-
use.
yeah. So that's why I wanted.
So there was an interesting discussion in the World UB conference. One of the American surgeons who had come, he says that he does not use a drain because by the time he finishes his second case, the first patient has already gone home. So they can't afford to use a drain. But I
Because-
think in my setup, patients like to stay for 2-3 days. I don't mind using a drain.
Because so far I have not used the drain for the single level.
Okay.
So because we don't use for the microdiscectomy,
Yeah,
we don't
true.
use for the tubular discectomy.
But here, because of irrigation, maybe I have the mental block, but I will try perhaps for a few cases,
Yeah.
see how it goes.
Thank you.
Okay.
Continuing with the next this speaker, may I continue with call upon Dr. Kiran Niraula. You will be talking on the endoscopic foraminal approach. Now the floor is yours.
Hello. Good afternoon, everyone. I'm Dr. Kiran. I'm from Nepal, and currently I'm working in Maldives in ADK hospital for last 6 years. So we are basically, because it's a small country, so basically we are general neurosurgeon, meaning we have to do brain, spine, endovascular, and sometimes even need to put baclofen inside the baclofen pump. So we are just basically, that's why general neurosurgeon working in Maldives. So till now we have in the spine, let me talk about the frequency of the cases. 60% of our practice is spine, 20% is brain, and 25% is endovascular. We have done open approaches, microdiscectomy. We tried tubular in few cases. The disc was out, but we didn't like that too much. Now UV is very new to us. But since our hospital was very aware of what the time is requiring, they have just purchased JoyMax instruments, and they also want us to get trained in these sort of small conferences and some training later on in India. The center they haven't decided. So this part of the conference, this part of the presentation, I had gone to Singapore NNI for 28 days of observership for UBE, uniportal, as well as for endoscopic foraminal approach. And for this topic, I had taken detailed pictures. That's why this presentation was possible. Let's start. So I think we have heard this kind of story very often, where a large, obvious herniated disc was removed. And yet, after waking up from the anesthesia, the patient said, the pain hasn't changed, the leg pain is the same. But surgeon is very sure that large chunk of disc was removed. So what happened? Surgeon can't be wrong because they have done a lot of homework in the OPD before posting the case. Could it be anything else? Could it be anything else than these? Wrong label surgery, irritation due to blood products, pain due to prolonged crude nerve retraction during the surgery. Could it be anything other than this? Yes, there could be. So where is the disc here? In sagittal slice, there is no disc because it's a mid-sagittal slice. So we cannot see, but in the axial, we can clearly see there is a foraminal disc, L2-3 in the left side. This disc will be easily missed if there is another obvious large herniated disc noted in the MRI in the same side, could be in the different levels. This kind of disc are usually not seen in sagittal slices if you do not look for it properly. Hence, careful axial slices need to be inspected. The other reason that why it can be missed is the same label in addition to the paracentral disc might have this foraminal component as well. So how to remove this foraminal disc? So the red one is the compressed nerve root and the purple is the herniated disc. So it's a very simple question because all of us are expert spine surgeons and neurosurgeons are there. Basically, it was prepared for general surgeon of Maldives a week back. So this was a question I asked. So in this foraminal disc, which nerve root is compressed? Exiting L2, traversing L2, exiting L3, or traversing L3? And why? We'll answer later on, but we know the answer. It's exiting L2 because it's a foraminal disc. So it's L2 left exiting root because anatomy clearly tell that. So in our general practice, basic practice, whatever we look for the disc, we are actually always talking about the traversing root. So, but in foraminal or paralateral disc, it's a exiting. So what can be the approaches for this disc? So it can be full laminectomy, yes, but chances of instability, lot of facet sacrifices need to be done, which is at least not ideal for this decade. So another can be microdiscectomy. Again, medial facetotomy is necessary. Still, you can miss some of the disc. MIS tubular discectomy, very limited field, very difficult to do actually. Lighting and everything is difficult. And paralateral extraforaminaltomy, open discectomy, that was done recently by the in the recent past. And another one is interlamellar endoscopic discectomy from the same side or from the opposite side. And the most advocated and appreciated one is transforaminal endoscopic discectomy for this kind of discs. So this is interlamellar approach from the opposite side. If someone is very good at uniportal or biportal, this could be very easy. But since I'm very, very new to this, itself looking at the picture itself, I found it very difficult. Going from this side, trying to approach the other side, saving the thecal sac and dura. So these are the different endoscopic approaches, interlamellar. Second one, drilling out the facet, and another one is transcambien. So this is the pictorial description of what is interlamellar and transforaminal. Interlamellar is, go in between the interlamellar space, drill little bit of above lamina and below lamina, and just remove the phlebum and get into the thecal sac. And transforaminal is outside the facets from the safer zone, that is Cambian's triangle, they say, from that area. So this is the clear anatomy. So traversing nerve root had just exiting nerve root had just exited above the disc level. If it is far lateral disc, it will go up and it will compress that. And the traversing will go a little down and it will exit from the lower level. And this is the safe area. So I tell, although I'm not someone who is very expert to teach other, but to my colleagues, I always say when they put the pedicle screw, if you want to do mistake, just put put the screw in the above side, not the below side. Above side, there is a cambium triangle, you cannot hurt anything. So MRI and diagrammatic, MRI was already seen that there is a disc and this a pictorial description as how this foraminal disc can be removed. And there was one case, a young Singaporean lady with Tamil ancestry came to neurosurgical OPD with 5 days of radiating left leg pain without back pain or neurological deficit at Singapore General Hospital. So surgical decision was made. Awake left lumbar 2-3 transpyramidal endoscopic decompression was decided by the team. So pre-op planning, since I was observing the case, so they properly stored this picture in their iPad. So clearly it is seen the exiting nerve root is yellow in color. So safe zone is the purple corridor. Behind that there is a pedicle. Above the purple there is SAP. So that was the safest area from which it should be approached, they taught me. So locating L2-3 level and medial pedicle line. Medial pedicle line is the medial most part of the pedicle. If you just pull the line from 2 points, that is the medial pedicle line. And the midline is on top of the spinous process. This will be required later on. So this is the surgical steps. So what I was shown and taught was either 8 centimeter from medial pedicle line or 9 centimeter from midline. You have to approach little above the end plate. So caudal end and the cranial end in the left. So first of all, from that point with the O-arm guidance, they put the spinal needle and the K wire was telescoped from the spinal needle, and serial dilators were directed towards the lower end plate, towards the lower end plate above the pedicle, safest zone, and the working portal or sheath was inserted, and this is what is it, working portal sheath oblique angle tip is always the side you want. And this is the summary. Summary means the K wire, serial dilators, finally the sheath. And firmly the working portal, firmly dock the working portal under the fluoroscopy over the lower end plate between SAP and the pedicle, that triangle, and drilling a bit of facet, SAP, and disc is out. So this was the center where I was training. I got my observership. I'm originally from hilly area of Nepal. So this is where I grew up from in Jhapa. I went to the harvest season. This is my balcony of my house. So currently I stay here just 500 meters away from here. And I'm currently working here in Maldives for last 6 to 7 years. And this is interesting. The partner for this conference is Inas Hospital as well. This was just after I finished my residency. I went to eastern part of the Nepal, and Dr. Diggaz and I established one neuro center there. It was our desk there. The first neurosurgeon, modern neurosurgeon of the world, and the first neurosurgeon of Nepal are there. So this is our team in Maldives. I'm Dr. Kiran. Dr. Chandra is also from Nepal. Dr. Robin is endovascular neurosurgeon. And Dr. Zaidan is Maldivian national who got trained under Dr. Papa in Kathmandu Medical College. Very good guy, down to earth, and master of theory. He knows everything. So we take his help very often. And I and we from my team welcome you all to Brain and Spine Conference 2026, organized by our team. Date will be announced soon. It will be around August to September. Thank you so much.
Thank you, Kiran, for your wonderful presentation and your interest towards the UB. Because of time constraint, I think we cannot take questions. So I request Dr. Deepak to hand over the memento. And next speaker will be Dr. Gopal Goka. He will be talking on the complication avoidance in UB surgery, discectomy and stenosis. So I would like to invite him for the talk.
Yeah, good afternoon, everyone. So I'd like to thank the organizing committee for giving us the opportunity to present our work here. So I'm Dr. Venugopal. I'm from Hyderabad. So we also started doing UBEs. So let's see what happens, how we are, because normally whenever we do a lot of cases, we usually encounter complications. But what exactly happens? Because normally to err is human, but how many errors are you planning to do? So are you planning to repeat them or not? So that is what is the main thing. So what is the surgical complication? So any unforeseen problems or adverse event that occurred during or after the surgery, making recovery difficult or it's impairing the surgical outcome. It makes the surgeon feel bad because we have already everybody been there. At the same time, when you're in the OT, it generates visceral response in the form of tachycardia, tachypnea, BP fluctuations, verbal lash out. You almost create a kind of hostile environment in the OT where if the surgeon is like that, everybody will be very uncomfortable and you are creating a bad example there. So you have to be more comfortable. You should be the cool head in the OT rather than other people. That is the main thing. So to look at what are the various complications, as you know, main thing is the bleeding, neural injury, dural tears, inadequate decompression. It could be stenotic component or the disc component, or you can have a soft tissue injury from the skin, muscle, and do not be in the theater, but later recurrence and the infections. Usually these are things which usually we have to look at. As I always say, like surgeon has two comforts. And always one comfort is he has to be comfortable in the OT. Second thing, he also has to look at the comfort of the instruments. Need not be that surgeon only has a microscope or the endoscope. He should be able to use it in a comfortable way where he can use the instrument where the instrument should be able to use it in a long run. So instruments, so if he is not able to use the instruments properly, he will damage the instrument. At the same time, he will cause collateral damage for the tissues. So it could be skin, muscle, bone, nerve, dura. So as we are seeing any kind of case, so though it is a complication for the surgeon, it is one of its complications for the patient. The surgeon cannot be able to, should not be missing the basic concepts. The reason putting this slide is not to reiterate all of them, but the surgeon should, each and every case, all the basics should be done and each person should have that concept of doing it. So these are the basic things which we have been listening to since morning. So I'll just, you can see them once. And as we can all, this slide has already been put, we are going very near to the field of vision. So that will basically give a clear cut view, because the more we can see, the chance of damaging are less. And another important thing which we need to learn here is when compared to open surgery, we have to use this tilting maneuvers, because we don't have an open area to manipulate the upcuts and all these things. So we just have to tilt it. So each and every time you just take an upcut or something, you just need a little tilt so that you can see. Need not be pulling and pushing, because though we are concentrating at the level of tissue inside thing, we are unnecessarily extending the scope, that dilatation, and it causes more tissue damage. And how the instruments usually get damaged? Usually the scopes can get damaged by the drill, or because if you are doing a lot of coagulation plasma near to the very tip of the scope, then usually it will also get damaged. Or by ablating the fat, usually the fat usually melts and it forms a thick layer over the kind of scope that will usually hamper the vision, and eventually the scopes get damaged. And here, if you can see, though the slides looks very busy, the whole idea of putting this slide is you can see the indications like triumphant protrusion, extrusion, sequestration, central, paracentral, foraminal. But if you see the last indication, disc with stenosis, though it was initially considered contraindication, now it also entered the indications. put more damage to the patient, and surgeon will not be happy. The type of anesthesia, as we know, GA, and usually we try to be doing a GA because the patient is comfortable, the muscle is under comfortable, you will not, it will take easily retractions. So epidural, you're on race with the time. So unless the surgeon is very, unless he is a kind of pro, then doing under epidural is little challenge for a younger person. And instruments, as we are in endoscopy, we should have as much variants as possible, because within the small area, unless we have an instrument, we won't be able to reach that part, and it will cause more complications. So we should have different kinds of probes. And energy settings, they are usual things, and the only main thing is near to the dura, don't ablate. That's the reason I have put cross. And then most important thing is the drills. As you can see here, the fluted drill looks like this, whereas the diamond burr we can have. So if you are able to use fluted burr in a reverse way, it cannot cut. So only the diamond burr only can cut. So the working zones of different diamond burrs is like you can do tip drilling, or you can do the side drilling, or you can do the withdrawal drilling. So these slowly, never try to directly go and drill them. It's going to punch a hole and it's not going to help anyone. So what kind of tip is better? Though you have so many tips, so usually it's a coarse diamond burr which is useful, because this coarse diamond burr is the one which usually that takes away the bone, and it compacts the bone and at the same time achieves hemostasis. So for example, we can just show a small video here, and you can see here, this is the burr which we are doing here. Whenever we are trying to burr, don't just direct burr. Keep on palpating it, drill it at the level of tissue and bone interface, so that the small ligamentum line gets cut off, and gradually we can go around. Similarly, we are going towards the medial side. Similarly, cut the tissue, go around, so that it will usually help the surgeon to feel it at the same time. You can withdraw drilling. This is called. So this will help the surgeon to extend as much he wants. Similarly, here also you always need to palpate it, little tease it out, rather than completely going around without later putting a dissector. It will save usually the time. Gradually keep on drilling. And preoperative image evaluation is very, very important, because sometimes the patient can have scoliosis and all these things, because we have to see the images. If without having these images in mind, once we enter, we are usually lost. And another thing is this triangulation. Don't ever think it's an equilateral triangle, because most of the time, if you see here, if you are planning to enter inside the disc, usually the instrument would retract the skin, and usually you will be struggling to enter inside. And you see, the more lordosis you have, the chance of having missing a wrong level, going into a different level, higher, more bone drillings will be done. So that also can be adjusted if you plan it in a different way, the trajectories. And if possible, you can always get one CT scan just to see all these different anatomies, because once you are inside, these are the things which almost looks like mountains rather than small things. This is a very important, because we are only focusing at a very minute points. So these things, the surgeon should be, once he has and have a clear-cut view of this, then the chance of he creating complications are usually less. And as I told, though initially you have a potential space, this is a true working space. Unless you create a true working space, you will have a lot of problems. The vision will not be. When you don't have a vision, you will create complications. And this slide was there since morning, because the main idea of showing it is, if your pressure is directly put onto the thecal sac, the chance of patient having blindness, headache, knuckle, neck pains, seizures are always high. So try to be that. And always try to follow a particular pattern where exactly you are learned with, or your mentor has taught you. So try to stick to that and follow that, because you don't try to jump from one point to another without having. If you try to follow one thing, then gradually the surgeon will chance of he making complications are usually less. And this is one of the important things, because most of the time, if people have to remember that two lamina are not in the parallel level. And another important thing is, surgeon causing more damage to the infilling has to be done. So as we gradually go up, this is more happens in a higher level lumbar spines, narrow lamina, severe central bulging disc, and into revision surgery, because we tend to go laterally. And after that, you routinely do these procedures. Most of the people have shown. During each and every procedure, the surgeon has to take appropriate precautions, so that the chance of complications are less. For example, once we normally, when we are in a micro discectomy levels, so we do retraction little, and we can see that little coagulation is done at the level of disc. So the chance of vision can be, though we can see that is immediate, don't jump onto it. Take a follow a particular thing, coagulate over that. So the chance of you having another visual impairment are less, so that he can be more comfortable at that level. Then if it is soft one, it easily comes out. Whereas if it's calcified, you have to use Carisons, Cusage, as you can see, osteotomes also you can use. And the bleeding usually is the one which irritates the surgeon. I'll show you some of the. Then traction injury is the most of the time is the one which causes trouble to the patient. And ligamentum flam is a friend. I'll show you some of the things next thing. That is related to the discectomy. Whereas as again you can see here the indication of the lumbar canal stenosis, it can range from the first is the easiest. As we gradually go there, they become the difficult. And relative contraindication, you have absolute contraindication. So people have to keep in mind, then gradually you can increase your gamut of indications. The target level is very important because that is the main point where which will help you to dock, and from there you can go on further. And the another important thing, if you are going to the opposite side, it's the exiting nerve root if you are planning to look at. So depending on the portals, however, like you just have to go little or go above, depending on the if you are going to see the traversing route or the exiting route of the opposite side. So this helps usually prevent further unnecessary bone drilling work. So recently there is an article which is there. This is one of the very good article which will tell you how to handle a lumbar canal stenosis in a particular organized way, so that instruments going in and going out are less. This video is there in the online. You can have a look. And another important thing is, though we take an incision like a straight one or a horizontal one, the facial incision should be medially, because without the facial incision being medially, we tend to, though we are concentrated during in the surgery at the level of ligamentum flam, we tend to push the scope more. It gets stuck at the level of fascia and it will cause irritation to the surgeon. He won't be able to reach. So that is the main. If you try to incision the fascia, we won't be able to go medially. So that facial incision is one of the very important points. And the flavectomy, as since morning you have been seeing butterflies and butterflies, what I just see is you have usually flavectomy. I don't recommend the piecemeal, but you have a whole fat butterfly. It is very cumbersome, obstructs the field, and sometimes usually cause thecal sand because people need to keep on compressing it and taking it out. So what I call it is a size 0 butterfly. I'll just see what exactly is that. So once you are inside monoportal, there you do not cut the ligamentum flavum. There is only a smaller one, whereas then you have then we have a different punch in the bones set, which usually makes the surgeon's life much easy. In a matter of 10-20 seconds, the whole ligamentum flavum can be taken out, and you can clearly see the whole thick butterfly becomes a kind of size 0 butterfly where only the thin layer remains out. And that usually creates a lot of real working space, and the chances of the saline flow will become much easier. And the surgeon, you can clearly see the whole thick butterfly has gone, only ligamentum flavum has remained. So this, if the surgeon is able to do, then the chance of he has already comfortably seen. He did not always take out the whole butterfly. You did not go behind a butterfly, but you can thin it out and be comfortable while operating. And this is how the surgeon should have a view of what is the end point. Need not look around, try to probe around. So each surgeon should have an end point, what exactly he has to look at. And this is with the thin ligamentum flavum, and this is once you remove that. And at the same time, if you go to the contralateral side, again you can see the pedicle margin, and again you can see the root here opposite side. And another important thing is you need to use the curettes in order to prevent nerve damages. So here again you can clearly see when we are using the curettes, when we are usually in the opposite side, so we tend to drill it, and once that thin part of the lamina is thinned out, then usually we can scoop it out, and that will we did not always put an upcut there. So once we get a little scoop it, we can clearly see the thecal sac. So we can completely avoid putting an both certain the dural tests happen because once we start putting the punch inside. So that is where we can clearly push. We can see the upper margin. We can see the thecal sac. So that will help the surgeon to make avoid complications. So similarly, you can use an osteotome also in the opposite side. Usually that is the ipsilateral you need not do. But on the opposite side, you can use a chisel and you can gradually thin it out, because where the opposite side lateral recess, when we are planning to do it, you thin it in such a way, the osteotimes have, it's a flat and a curved one, so you can use a different one, and based on that, gradually we hit it in such a way so that gradually it gets completely separated from completely is mobile. So it is easily moved out, and we did not put in a punch and it will easily come out. And similarly, when we are doing with the lumbar canal stenosis patient, they have an osteoporotic bone. So we can simply use a bone, or sometimes what we do is this pressure hemostasis. This pressure hemostasis is the one where when we are looking at, we can clearly see there's a bleeding. Just use a dissector and start compressing it. So automatically the bone bleeding will stop. We did not come out and take bone wax and all these things. Sometimes that simple maneuver will help us a lot of time. So this, just crush it, just keep on pressing it, and the hemostasis you will achieve hemostasis. And as I told you, to prevent fracture of isthmus, you have to know how much you are drilling the isthmus. And the most important thing is the dural tear. So as you have seen, the dural tears are happening. Why does it happen? It is mainly because of unpracticed handling, lack of understanding about water dynamics, because it will create a fold, adhesions, massive bleeding, the blind procedure, and you put a drain tip which is sharp and directly hits it, or repeated damage because once we drill the facet, it is sharp, then it will keep on hitting the dura. And in endoscopic surgery, when the fold happens and this narrow field without creating this thing, so youngsters usually have a tendency to create a dural damage. And another important thing, as people have been since morning, we have seen, because it is the meningovertebral ligaments, how exactly, as we can clearly see the meningovertebral ligament here, we can clearly see that is the meningovertebral ligament. It looks like this, and gradually when try to push it or pull it, they get clearly, it will completely rips off the dura, and we can start seeing the thing. And gradually, we can see usually we tend to cut it, and so that once we separate it out, we can use a UBU hook or coagulate it and cut it, or sometimes now it got cut, and gradually we can easily retract it. But you should have an idea what exactly you are looking at. And these are all the things, this is how they look like, different ways, and these are the different things which cause usually the dural damage. What I need to say is, delayed dural tears are due to sharp facet margins, drain tip irritation. The dura gets very thin in elderly, so they also get damaged. What I say is, most of the time when, as I have seen the previous explainer, that they could not look at the size of the dural defect. As we know, our scope is around 4 millimeters. Just put the scope as near to the defect as possible. If it is the size of it, it is 4 millimeters. If it is more, then based on that, you can take an action. So for example, if it is 4 millimeter or less, sometimes we can just avoid, put a patch and run it. If it is in between, try to put a Duragen, push it inside, put it overlay, and gradually put a glue. That usually solves it. But as you can see, some other things, there are different methods. This is one of from the article by Kim Choi, where he has put a Tacosil. And another thing is they have even the staples kind of thing, 3 millimeters this thing, but you need another port to do that. And you can directly use a dural repair. And contralateral decompression, try to use a reverse drilling, which is safe. And you have different kinds of chisels we can use. Another important, to avoid the instability, we try to use these curved chisels where we can completely avoid drilling using this sharp margins of the facet. So facet joint preservation is very, very important. And epidural bleeding, as we can see, we can clearly avoid it. This is the last small short 10-second video. And normally what we see is, when you have a bleeding like this, don't worry. Try to just focus where exactly you are looking at. Try to go in, and gradually now we can see the bleeding is coming from there, and you go inside and try to locate, and you coagulate that area. And so once the coagulation is done, it immediately the vision will get perfectly clear. So the surgeon need to have patience. Without patience, you won't be able to see. Now it's completely got clear. Yeah, as I think I'll not be dealing with more of him, because yesterday was dealt with all this thing, bleeding. So practice not always makes perfect, but unless you know how to avoid the mistake. Thank you for your attention.
Nice presentation and very important topic, Dr. Venu. So that it was late. So we'll jump into next session. I request Dr. Deepak to present a memento. Next, I invite our next speaker, Dr. Prakash. So UBE, changing the landscape of MIS, minimal invasive spine surgery.
I must say good evening to everyone. So, respected co-chairs and the organizer, uh,
Yes, ma'am.
respected co-chairs and dear organizer, thank you for the opportunity. Today, from the very beginning, everyone is talking about UB. Obviously, this is a Ubecon. So my talk is almost always this covered. So I am just repeating as Deepak sir told that repetition, so that it will be rooted in your mind and you learn new things. So there is no conflict of interest today. Before starting, I would like to acknowledge my mentors, because of who always persuaded me for this all new technologies. For and foremost, Professor Mohanraj Sharma, who is the past president of Nepali Society of Neurosurgeon and currently is the Dean of Institute of Medicine, Maharajganj, Silpakar sir, Professor Om, and my mentor in this UB surgery, Professor Siolung Park, and my friend Dr. Edmond Jonathan from CMC Vellore. Because of them, I got more interest in the UB spine surgery. So this is my overview. No matter how expert you are, but you have to always think that every expert was a beginner one day. Until and unless you feel and realize this thing, you can never learn new things. One may do a complete spine surgery like in half an hour, and you may need 2 hours, 3 hours, 4 hours. If you want to know the story of Professor Om, who started UB initially way back 2 decades ago, he used to say that he started UB spine surgery for 9 hours, and he quitted and converted it to the open surgery. So please don't get disheartened if you are fail. Failure will teach you new things. So even the pioneers, they have such history. So why don't we have? So accept it and go ahead. So going to back about the history, there is a paradigm shift in the spine surgery. You see the first image, there is a big incision and go for the spine surgery. And there is a large skin incision, muscle retraction, patient will obviously have a postoperative pain. Whereas shifting to the minimal invasive surgery, you go, there is a percutaneous screw placement, and going to the tubular retractor system and performing the surgery. And again now the new horizon is again endoscopic UV surgery. So everything is changing, and what will be the new horizon? So what is UV? Everyone is familiar by this time from yesterday's cadaveric workshop coming to this time. So it is just a 2-portal system. One is working port, another is a light source. And it matters about the continuous irrigation system. It is very important after this putting this triangulation. And the best advantage of this UV system is bimanual mobility. The one who is well versed in the open microscopic surgery, they can adapt this UV procedure very easily, because the anatomy is not going to change. The anatomy is same. If you have a good hand-eye coordination with other like cranial endoscopic surgery or anything, you can easily adopt it. So there is not much to worry to go ahead. So why UV? Like UV is mainly for, it is because bimanual handling is easy, and there is a reduced blood loss, and the muscle trauma is less, and it minimizes postoperative pain. Patient will feel happy, and thus there will be a fast recovery, reduce hospital stay, and finally the cost. Though initially while buying the gadgets there may be a investment, but later on it will be of little cheaper. So if you go to the history of this endoscopic uniportal or biportal, everyone has talked, and Dr. Thulung has already highlighted on the history, starting from Anthony to Hoagland, from the inside out technology to outside in technology, and it actually this UB, the concept of UB came out after this Abdul Ghaffar, who started doing arthroscopic surgery, and then the same principle started. But in arthroscopic surgery there is already a predetermined space where you can play around. But in this, because of this multi-feeders, lamina, this and that, you have to create an artificial space. So you have to be patient while creating this space by drilling. Talking about this UV protocol, there are 3 persons who has revolutionized the UV surgery: Professor Wang, Professor and the Professor Xiaolong Park. The Park is the pioneer of this present day UV. It is because he has developed different technology and different techniques, contralateral approach and other technology, and he has been the tutor for many of us in the floor as well. So I am not going in detail about the terminology, everyone has talked about this thing. So basic difference between uniportal and biportal is that visualization in uniportal is good, but it is better in case of biportal, and manipulation is limited in uniportal because of one instrument, whereas because of biportal the manipulation is much more easier, and the learning curve in the uniportal is little long, whereas it is those who are trained in microscopic into this surgery, they can easily take up this surgery, so it is little shorter. And the tissue injury and skin incision is little bit less in case of uniportal. It is because there will be one incision, whereas in biportal there will be a double incision. Obviously there will be a little bit of more injury. So the concept of this basic concept is, in case of in microscopic surgery, the light source will be outside the operating field, so you have to create a bigger space to view the same structure. Whereas in uniportal you go to the area, but with a single instrument, the manipulation is a little bit difficult, and you may not achieve what you achieve in a biportal endoscopic surgery, because in biportal your working port and the endoscope source you can mobilize. You remember the chopstick movement, so that once you start, you always assume that you are just trying to negotiate both the end of the chopstick, so that you will not get lost into the field. So there are many indications nowadays. What the pioneers say and what we have been feeling and what we have seen is, what surgery can be done with microscopic surgery, that every surgery can be done with the endoscopic surgery. There is no no contraindication for endoscopic surgery. It depends upon your expertise, your experience, and what you are exposed with. So every surgery can be done with endoscopic. I have seen, I have read, and many of you have the same experience. So there is no any like absolute contraindication. So how to start a UV surgery? If you go to the AO Spine website, they have nicely highlighted the 10 essentials of UV surgery, and those who want to start the UV surgery, they can go to this AO Spine website, and they can see this 10 steps. They have written very theory, pictorial, everything is there. So with this, I have highlighted these steps into 5 points. Like patient positioning. Patient position is of paramount important, as everyone was saying. This abdominal pressure, yes, your abdomen should be lax as it is holding the in my center. I do this on the Allen's frame. It is so that it is easy. It is carbonated frame. So once you place this patient, this pressure point are well guarded, and your abdomen is fully laxed, and you can manipulate this lesion, this abdominal position whenever you like, and all these pressure points are well padded, so that you will not have this peripheral nerve injury or compression later on. Another is portal placement. I am not going in detail about this point. Everyone has clearly mentioned triangulation technique, decompression, and continuous irrigation technique. So this is my operation theater anatomy, and I would like to say that we have a OAM in our theater. It was the first OAM in the country, and it has really helped me to do the complex spine surgery other than this UV surgery. I have not used this UV for this OAM for UV surgery, but I have heard that it has a very good this thing. So I am in contact with my friends who can guide its use on this UV surgery. So making incision, again same slides have been dealt in detail. So while drilling, the one thing we must know is that if we have this guarded type of drill, there is a less chance of injuring the dura, this knob injury or neural structure. But not having that, it's not that we cannot start the surgery. We can do by lowering the speed of the drill like 30,000 or 20,000. But with this guarded drill, you can go to the normal speed. So the surgical step, again, there is a detailed surgical step from beginning to end. I'm not going to detail all. Many of us has already demonstrated how to make the incision, how to do triangulation. So it is easy for me. So making a proper port is very important. It creates the continuous outflow, which is necessary to obtain the optimal visual field, bleeding control, and constant hydrostatic pressure within the limit of the safety. Is Professor Amit has already highlighted on the hydrodynamics of this. It is totally dependent on how the irrigation fluid is going in and coming out. So if your irrigation fluids stagnancy is more, then there is a more chance of bleeding, and you will have more chance of increased intracranial pressure. There have been case reports of raised ICP and patient has gone blind as well. So multi-feeders and creating this space, which has already been dealt by the previous speaker just now. And one thing while drilling, we should be like cautious about while drilling this IAP and SAP. You know, while drilling this SAP, we must be careful. It is because this is the area where this exiting knob roots part, just like this is the pedicle, the exiting knob roots parts like this. So while drilling this SAP, we must be more careful. So this is called the danger zone. It has to be drilled at the last of the procedure. And when you start the drilling, one thing what I want to highlight is because the flavum is the thinnest in the midline. So when you drill, usually what drill size will be like 3.5 or 4 or 5 mm. So when you drill, just drill 2 times the size of the drill, so that you will have enough parts left, so that your instability issue will be resolved, and come laterally just 2 times the size of your bore. Once you see the epidural fat at the midline, because at the midline you will see the epidural fat for the first, so that it will be easy. And once you see the knob structure, thecal sac knob, then the chance of complication will be less. So these are all the instruments required. Everyone has talked in detail. I am not going in detail about all these things. So dissector application. So this is the representative case of contralateral this keyhole approach to decompress the discs on migrated discs on the other side. So you see, I have gone through this this left-sided approach to attack the discs on the right side. So if you are well versed in the open surgery, the contralateral approach becomes more easier, believe me. So root retractor, it is helpful in this taking out the discs, and this is the annuloplasty. After taking out the discs, it is usually, if you do annuloplasty, in endoscopic surgery, the principle is always take out the pathology. Don't do the preventive surgery. So once you take out the discs, it is better to do annuloplasty in all cases. Now, what is the challenge in endoscopic spine surgery? It depends upon, like this curve shows that after this your training, you have to decide whether you want to be a just competent surgeon or you want to be an expert surgeon. For that, you have to come out of your comfort zone. If you see, after these careers of 5 years, 10 years, 15 years, and 20 years, if you want to learn new thing, it doesn't come without sacrifice. So if you want to be expert, you have to adopt the change. If you just want to be a competent and good surgeon, it's okay. It doesn't harm you. It's because there is a steep learning curve, the irrigation risk of pressure and hematoma, and the instrument adaptation, and it's not suitable for severe disability. So there are lots of papers, because everyone has talked about this UB, so I don't want to show the evidence. Evidence speaks itself. There are hundreds of papers on UB, contralateral approach, and UB for tumor surgery, UB for intradural pathology, UB fusion. So I don't want to go in detail of this all evidence. Every one of us has already accepted and talked about it. So what is the UV status in Nepal, the current scenario? Dr. Nikunj will talk about this in detail in coming talk. So it is in the early adoption phase. It is not the old age surgery in Nepal. Very few centers are doing it, but the young generation, there is a growing interest among young surgeons. For that, we need to have a regular workshop, cadaveric workshop, global this collaboration. So Nepal has a chance to impact MIS early now. So where is the road? The road ahead is UB, TLIF and biportal fusion should be started in all the centers, though many centers are doing in Nepal. So UV application in cervical and thoracic in all the centers should be done. And integration with navigation robotics is coming up. So UV has the potential to become the standard of care in MIS surgery. Always, difficult road often leads to beautiful destination. The best is yet to come. So once we accept the change, then always will reach the beautiful destination. So where is the road? The new road is always UB. So coming to the conclusion, UB is a transformative innovation in spine surgery. It is safe, effective, and reproducible, and minimal invasive benefits with the open like freedom. UB is not the future; it is the present. So changing spine surgery today. So the journey of thousands miles begins from the one step. Why don't we start the new journey from today? Thank you.
Nice presentation. Prakash, any questions? Questions from the audience? So, next, I invite Dr. Suresh for his topic barriers and challenges in adopting UBE spine surgery.
Good afternoon, everybody. It's more like my experience and difficulties that I faced in the initial phase of my journey to UB. And most of us in conferences like that, we discuss about our achievements and how easily uh, uh, we easily adopted this thing and incorporated it into our practice. But the real scenario, it could be different. So especially for young neurosurgeons and beginners like myself, so who are independently practicing in some centers outside major cities, it could really a difficult thing, or it could pose some challenges that if we understand in the beginning or before we take up this thing into our practice, it could be much easier. And that's why I plan to have this talk in this session. So endoscopic spine surgery is exactly not a very new thing, though the modern endoscopic spine surgery started in the last decade, and we are not that late as Nepalese neurosurgeons or spine surgeons to take up this thing. The whole world is now starting, and it's the beginning of UB or true endoscopic spine surgery. So why adoption matters? A lot has been talked in the earlier lectures, so there is nothing new in this slide. So we all want to take up this new technique that enables us for better visualization, early recovery, a minimal scar, and a lot of good things with endoscopic spine surgery. So even though this is pretty good, there is so much prospect in the endoscopic spine surgery, yet it is very difficult to transition from open or microscopic surgery. So let's dissect few of these things and see what's there. So there are a few technical challenges or barriers like steep learning curve, challenging hand-eye coordination, limited mentors and structured training programs. Especially most of the countries, I see it's in India or Nepal, our training centers or the medical colleges or where the residency happens, they are still reluctant to take up these things, and so the training centers are not quite equipped, and we have to travel abroad to gain this experience and start these things. So limited training opportunities inside the country is one of the very, very difficult thing. Most of the training centers in India, they would charge some fees, and those fees are also quite some amount. So we need to develop our own centers that could train our young neurosurgeons and help them take up this thing. So teaching institutions and universities, I request my colleagues to please come up with this and move forward. So in early phase, there is always fear of failure of surgery, or whether you would need to convert it to open up the cases, and not completing the case itself is could be embarrassing moment for some people. But what I think is everybody who has started endoscopic spine surgery, there is nobody. I don't think there is anybody who completed his first case in first go. So it's not a big deal. So I want to that message. So as a surgeon, surgeon reluctance, comfort with conventional approaches. So we are comfortable with our conventional approaches. We finish our cases in time. And if you are a busy surgeon, taking up this case and taking up this surgery and spending like 4 or 5 hours for a beginning case would quite be difficult sometimes. So it could sometimes limit practice. Limited exposure during residency, definitely residencies we don't see most of the residency programs taking up this still to take up this new dimension. So patient awareness and expectation is there. So though the surgeons and the industry is not totally built up to cater all the patients with endoscopic operations, patients now are demanding, and so there are maybe unrealistic expectations from our patients also. So affordability and access may be an issue because UB expanding UB to complex cases, maybe you need a lot of equipments besides the working tower or endoscope. So we already have discussions on intraoperative O-arm image guidance and things like that. So it could pose a significant amount of money or investment in the part. So in the infrastructures, I already discussed. I took this picture yesterday from Ninas, where they had this O-arm. So expanding horizons is always there, and it takes money and dedication and investment opportunities, or investing hands that support the surgeons to build up the practice. So in wider implementation, we still have the gap of research and larger long-term comparative studies that we still need to develop, so that it's the validation of these EB spine surgeries is there, and we no more have to discuss about compare endoscopic spine surgeries with traditional open or microscopic surgeries. So how do we bridge this gap? So the breeze may be easier for senior neurosurgeons, or maybe good for a surgeon who has a team that is supportive for the evolution. But sometimes independent neurosurgeons could face some problems. So teamwork is utmost important. Teamwork consists of a cooperative anesthesiologist, helping hands in the operating theaters that would cope up with your initial learning curve, encourage you, pat your back, and support during your complications and things like that. International collaboration and skill transfer is always important. It's what we are seeing these days, thanks to all the supporting companies and international faculties that are there to help junior surgeons to build their practice, mentor them, and help them in the beginning. So besides this, careful patient selection in the initial phase, maybe a simple desk or a simple decompression would be helpful. Once you begin your practice after a couple of weeks training with mentors, you could start with this. But what I feel is before you start a UB or spine practice, you good to be good at good at your anatomy and orientation with a couple of years of maybe open spine surgery practice. So that would definitely build a background for yourself in beginning this thing. So patient education is another important thing. So only we got to be realistic about setting the picture of spine surgery. Already spine surgery is quite a bit disrespectful, or it comes with fear for if we see the patient. They are